So thank you for spending some time with me. I am going to be reviewing the Soft Mandibular Appliance in pretty much a good bit of detail. You shouldn't poo-poo this appliance because it seems so simple and you may have been using it previously in a different way. But this is one of my most important, if not my most important, initial appliance. So I always provide a soft mandibular appliance to all my TMD patients while I'm doing my construction of the mandibular orthopedic repositioning appliance. So please, I use this for everyone. And there was a period of time many years ago when I was frustrated where I was primarily using this appliance to manage TMD patients. So I found that it is not the ideal appliance for managing TMD patients, but it serves as a really good initial appliance, and it does manage many patients very well. All right, so this presentation is provided by the Atlanta TMD Institute. My name is Dr. Mark Podolsky. And we have several purposes when I formed the Institute. First is to educate dental and medical professionals in TMD. And this is what we're doing right now, isn't it? And thank you for joining me. And the second is to develop knowledge of temporomandibular disorders. I think so much is deficient in this area right now. There are just, if I listed out some of the really weird things associated with like sleep or gait, walking gait, or postural management, whole bunches of stuff, motor problems related to TMD, it's just amazing, but there's very little research done, very little documentation, absolutely no interprofessional specialty discussions. Next thing is to successfully treat patients suffering with TMD. And I want you to learn how to do TMD. Absolutely, I do. But if you want to refer patients to us to manage, we're happy to do it. And that's actually where much of the money comes from in order to fund our activities. So when in doubt, refer. We appreciate it. But otherwise, we want you to learn how to do TMD. And that's the purpose of this particular presentation. So again, the topic is the soft mandibular appliance, and I'm going to try to give you both theory. Why does it work? Why are you using it? I think whenever you're using an appliance, you should know what that appliance is doing, what you're trying to accomplish, and also to know that there are limitations to just everything you do. And I learned that with the soft appliance. Again, I think I read a paper, 1989, I think it was 86, published by Frickton, where he said 90% of the pain and chief complaints of patients with TMD are muscle related. So that just drew me back, and I said, well, Lord Almighty, if I do that, why don't I sit back and start thinking, if I can get rid of the muscle pain, I'm going to have a 90% success rate. And believe it or not, the soft guard helps a great deal, and it's more like a 50% success rate with the soft guard, but it is not a long-term appliance. It doesn't do many of the very important things that the MORA does, the mandibular orthopedic repositioning appliance. And I learned that because I was using it for several years, and I went up, I think it was to Boston, and I spoke with my mentor, Dr. Harold Gelman. He's a New York kind of guy, puts his face in my face and says, listen, man, you're just not properly, fully treating patients with what you're doing. And I looked at him like, geez Louise, I do pretty good. And it's so interesting. And then when I went back to my practice in Atlanta, sure enough, God plays his role, and a young medical student from the University of Alabama who was previously my patient, soft guard care, came in terrible pain, and Lord Almighty, I was taught a lesson, and I did find the fault with my treatment, and I subsequently treated her with a MORA very successfully. And again, theory, why do we do it? And then practice, what do you have to do What are the faults? What are the things you should do? What are the things you should absolutely not do? So let's start by talking about what a reflex is. And when you go into your physician on a regular basis, so certainly a neurologist, they're going to use a little hammer and they're going to like hit a certain area, and they expect that you're going to jerk in a certain way, and everybody does because of what's called reflexes. So it's a automated response. You don't have any part, your thought has nothing to do with it. It just happens automatically, and it's part of the autonomic nervous system. So what is a reflex? So a reflex is an automatic reaction involving nerve cells, because nerves tell muscles what to do, right? So that is not controlled by the brain. So you can't control it. Your nerves are going to tell your muscles what to do without your control. And it does not involve choice. A reflex is a physical reaction. So it's actually something that happens. There are digestive reflexes. There are other reflexes also. So I'm going to say here, yeah, we're talking about the type of reflex that we're talking about here is a physical reaction. Okay, so it's a physical reaction to something that you cannot control. So for example, if your finger touches fire, you're going to pull your arm back quickly. You're not going to think about it. There's going to be no thought related to it. Got it? No thought whatsoever. And the Cambridge Academic Content Dictionary breaks it into two things. Re means back, flectere to bend back, bend away, all right? Bend away or back. And here we have the patella knee reflex arc. Got it? And when we think about this, okay, so they hit a little hammer, which goes to a sensory neuron, which is, you look on the top of the leg, it's a sensory neuron. You're sensing something that goes into the dorsal root neuron or ganglion, right? And then it goes into your central nervous system. Got it? Dorsal senses, ventral's motor, and dorsal sensory, ventral motor. And it goes into a horn in the spine. It connects then to motor nerves. So you've got sensory nerves sensing something. Oh, I just got hit. How do you know that? Because you sensed it through sensory neurons, sensory nerves. And then an automatic response occurs with the hamstring muscle, where the motor neuron causes you to go forward. Bang. Got it? And if you look through there in this particular part, you have a dorsal root neuron or ganglion, and then it goes into this, that's external to the central nervous system, and then it goes inside the central nervous system, which is the spinal cord. White matter are axons running up and down, and gray matter are cells, the actual cells of the of these nerves. And then interneurons are between other neurons. Got it? So you got the patella knee reflex arc. You hit it, you get a sensory neuron, goes into the dorsal root, connects to another cell. Then the axon goes down into the central nervous system, and it connects to several other ones. See how it's going into more than one now? It went from one to multiples, and the motor neuron causes the hamstring muscle to respond. Kind of crazy. Sounds stupid. You might be mad we went over this, but guess what? You've got to be thinking simply like this when we start talking about the soft guard, because there are lots of motor responses in the mouth. All right, so the first thing that I want to talk about is a joint reflex. So arthro means joint. Got it? Arthritis means inflammation of the joint. Arthro means joint. Kinetic means a movement. Remember we said some sort of movement. So we have a joint movement reflex, the arthrokinetic reflex. And this is extremely interesting, and you must understand this. This is the central core of understanding TMD. It's a central core of understanding orthopedic medicine in general, okay? It's very important, and we're going to go through this. So the arthrokinetic reflex is a property of joints. It's something that joints do. Movement of a joint causes reflex activation. So you're moving the joint, and there's going to be sensory information going in from the movements. Got it? And then there's going to be a reflex. All right, so you're going to, movement of a joint causes reflex activation or inhibition of the relevant muscles. Let's just talk about this. This is really important, and I'm going to kill it. I want to kill it. I want you to understand it. So basically, what happened here was they did a study, and I believe with cats, and they decorticated the cats. They took their brains out. Oh my Lord, cut their brains. So now they were just looking at the joint without central, without cerebral input or spinal input. And they noticed as you move that joint, the muscles start contracting. Wait a minute, that doesn't come from a central nervous system effect. It comes from the actual joint telling the joint's muscles what to do. Got it? So the joint and the muscles, they're friends. They work together. Got it? And there's an automated control that the joint itself tells the muscles what to do, because we start thinking about that patella knee flex, and that's a central nervous involved reflex. This one is not. This one, where if you have a damaged joint that's giving all kind of crazy information out to the muscles aren't going to behave properly, and you're going to have all kind of muscular issues. But again, what is the core understanding here? That the actual movement of the joint, the sensations inside the joint, they have an intimate relationship with the muscles that move that particular joint. So there's associated muscles, and those muscles are activated or inhibited. They're controlled directly by the joint itself. So the arthrokinetic reflex, I don't know if they were brothers or not, but they were Cohen and Cohen. That was, I think they were looking at the knee. And so R.K. Clark, a British guy, he's like, wait a minute, does this happen with the temporomandibular joint? Does the temporomandibular joint have an arthrokinetic reflex? In other words, when we move the condyle in the mandibular fossa, is there changes to the muscles directly? Are those changes inside there causing some sort of craziness with the muscles? And the answer is yes. The answer is yes. He did the experiments, and the paper is entitled Temporomandibular Arthrokinetic Reflex Control of the Mandibular Musculature. Remember now, the joint is intimately related to the mandibular muscles. Got it? The muscles of mastication. Okay, so is there a mandibular arthrokinetic reflex? There is. The arthrokinetic reflex is a property of the temporomandibular joint. Okay, so there we know it. And this is, please, I want you to be listening to me, because I have all these agreements and disagreements in general with the way many patients are being treated. So the first thing is, many people believe that osteoarthritis occurs over 3 to 5 years. It degenerates the joint, and then finally the patient's pain-free. Now they got a completely tore up joint, but it's pain-free, right? So wait a minute, you've got the disc and all the attachments like hamburger, and there's nothing there that is working correctly. And if we are treating patients, do we not want to restore the arthrokinetic reflex, right? And that would require that the anatomy within the joint is as close as possible to normal anatomy, right? And there's one physical therapist that believes that, okay, well, what you need to do if they can't move and the disc is anterior is to keep on pushing it forward and forward and forward until eventually this hamburger and they can move. And Lord Almighty, we restored the range of motion of this patient. But now the patient has hamburger, right? And all the normal control patterns within that joint are messed up, right? Completely. But again, this is a very important concept that you'll come back to, and it does relate to the use of the soft guard, and that's why I'm presenting it to you. And it also illustrates some of the beliefs that I have in TMD. So form and function are intimately related, I think, all throughout my undergraduate courses. And throughout dental school anatomy, we were taught that anatomy matters, that we could look at something and see if it was normal, and that was the evolutionarily derived perfect system for that particular joint or structure. And whether God did it or nature did it, I feel God did it, but indirectly, we don't want to get into that conversation. But I think that the anatomy is critical. So let's take a look at what Dr. Clark had said. So there is induced dysfunction. In other words, because of the problem with the actual way the joint dysfunctions, you're going to have induced dysfunction of regionally discrete groups of articular mechanoreceptors. So how does that arthrokinetic reflex work? Well, there's sensory nerves, right? And sensory mechanoreceptors. A mechanoreceptor determines the mechanical things going on inside and sends that into the central nervous system. So induced dysfunction, we have dysfunction of regionally discrete groups of articular mechanoreceptors, was shown to result in specific, now he's saying specific, changes in static and dynamic reflex motor unit activity. What does that mean? It means, well, the way that the jaw hangs and sits has changed, and also the way the jaw moves changes. So when we say changes in static and dynamic reflex motor unit activity. So abnormal muscle function, which we see in TMD, can come from abnormal anatomy, right? Internal anatomy of that joint. So this is, again, where I believe strongly in anterior repositioning appliances, and we'll go over that over and over again, because it's not so much that it's an anterior repositioning appliance. It is an appliance that puts back the original anatomy that joint was supposed to have. And that when you sit, you think, where's the articular cartilage? Where, and why is there no articular cartilage in the back of the joint? We think about all of this. And then you say, well, where's the joint supposed to be? And we want to put that joint back into place as best we can orthopedically. That's the objective, not the appliance. And some people, they say, well, you talk about this appliance, everybody gets upset. Well, I don't use that appliance. My mentor here, he says that you can't do that appliance. This is the appliance that we need. And there's no Cochrane, you don't want to get me started on all of this. All I want you to do is, again, I'm hitting this really hard because I want you to be thinking like an anatomist, like a scientist. Again, this paper proved that induced dysfunction of regionally discrete groups of articular mechanoreceptors was shown to result in specific changes in static and dynamic reflex motor unit activity. So the muscle responses changed because of the internal pathology. Got it? Not only just the movement of the muscles, but the way the muscles position themselves. And that's what this says. Again, this paper is just really key, and I want you to be thinking, well, what causes everything? Don't just say, oh my God, this is deviating to the left, it must be this. Well, it could be 2 or 3 different things, right? And you need to differentiate between those 2 or 3 different things so that you can choose a treatment pattern that will be effective, rather than, oh my God, I use this appliance on every single patient. And although I'm breaking this rule a little bit, I'm going to explain why. But again, derangement of the operations, derangement means the arrangement inside the teenage kid's room is, it's crazy. The arrangement is out. It's deranged. Derangement of the operations of this reflexogenic system. In other words, this joint has reflexes, and when you derange the internal parts, the reflexes change, as by trauma, when someone gets into an accident, disease, osteoarthritis, inflammation, arthritis, whatever it is, or malocclusion. Malocclusion, I poo-poo on that a good bit because mal means bad, bad occlusion. Teeth move. We know that. Orthodontics proves it. If teeth didn't move within the magic alveolar bone, which allows all of this, that we wouldn't be able to do ortho. So teeth move based upon the stresses and strains applied to them by the surrounding muscles. So technically, if there's a joint problem or the reflex muscle problem, it's going to cause muscle pressures on the teeth and it will cause a malocclusion. The joint caused the malocclusion. Oh my Lord. So this is not what everybody thinks. They say, well, he has a malocclusion. They don't say how it got there, but this malocclusion is causing problems. Excuse me? That malocclusion occurred based on the balance of the tongue, the cheeks, the buccinator, the masseter, all the muscles in the surrounding area, the tongue, come on. And all that muscle dysfunction is going to cause malocclusion because it places forces on the teeth that cause the teeth to move and cause the teeth to go out of their correct position. Got it? Very important. And then again, derangement of the operations of this reflexogenic system, as by trauma, disease, or malocclusion, might result in changes in the normal pattern of mandibular muscle activity. And this is what we see, right? You'll palpate one side, it hurts like hell, and the other side doesn't. What? Geez, what's causing that, guys? We need to know that. Don't just jump in with the same appliance, because wait a minute, if there's pain on one side and the other side's normal, why are you treating the other side that's normal? Oh, geez. So there may need to be some asymmetry when you're in your treatment. Oh my Lord. Why? Because you're putting back symmetry by using an asymmetrical appliance that treats to symmetry. So if you've got a crooked mouth, you're not going to put just a flat appliance in because it's going to make the crookedness more worse. Got it? So then when I start jumping on this stabilization appliance issue, almost always, if there is a canting of the upper jaw, and you put a stabilization appliance and you don't do it properly because the mandible wasn't moving correctly, you're going to build in the pathology. You're not going to straighten things out again. But again, that these reflexogenic problems cause changes in the normal patterns of mandibular muscle activity that may be significant in clinical circumstances. So it is probably a good thing to sit, perhaps, and read this paper. The Institute has most of these papers. So if you request it, we can get them to you, or you can look them up using Google Scholar. So yeah, I talk a lot, and I'm hoping that you'll let everything absorb in your brain and suck in the information. And most likely, a lot of it's just going to be annoying. And then I'm going to tell you, you're going to come back again in a year or two and say, oh my God, I didn't quite get that. He said that. So it's really, really important that you listen to all the basic science stuff and understand what's going on with your TMD treatment. So the periodontal sensory denervation, what is that? Periodontal sensory. So the periodontal ligaments are they're exquisite, and that when you bite on a tooth, that tooth knows the direction of the force, how much the force is, because you compress only part of that ligament. Got it? So only certain fibers, let's say when you're biting outward, are going to push and compress the ligament on one side. It's going to send the information to the brain. The brain's going to say, oh, the mandible is moving this way because this tooth is being compressed this way. So the periodontal ligament is incredible. The more I think about it, it's just incredible. It tells us stereoscopically where everything is based on the way teeth are being touched, number one. Number two, it is magical and mystical because it integrates with the alveolar bone. So you can have a tooth erupt upward, putting tension on the periodontal ligament, which causes bone growth. So you can actually have vertical bone growth from that periodontal ligament. It's just amazing. And you know that because how many times have you prepared a crown, the temporary fell off, they come back in 4 weeks later, and now that crown is touching, that prepared crown is touching the opposing tooth. It's amazing. We can grow vertical bone with periodontal ligaments. And this is like a very important implant concept. But anyhow, there's lots of information coming into the central nervous system about the position of the jaw, and the function of the jaw, the motor part. And we want to calm down all this information, right? And one way we do that is we cover all the mandibular teeth with soft plastic. Now the teeth can't physically feel the opposing teeth hitting in certain manners. So all that information is gone, right? Or at least decreased significantly. So by covering the crowns of the teeth with soft plastic, the fine proprioceptive sensation of the periodontal mechanoreceptors is removed, and this eliminates the proprioceptive information sent to the mesencephalic nucleus. So let's do a quick exercise. Close your eyes, take your right hand, make your forefinger extend, and now while your eyes are closed, place the tip of your forefinger on the tip of your nose. And almost everybody can do that. And I think that's one of the most amazing things, really, that we have, that God gave us. You know where the tip of your nose is. In your brain, there is a actual system, stereoscopic system, that knows 3D where your nose tip is. And then get this, it knows where the forefinger is, but not just where the forefinger is, but as your whole hand moves in space, it can direct it, right? It's kind of like a missile locating system, and it's all amazing. Really, it really is. And the mesencephalic nucleus is part of the trigeminal system, and we are in charge of the trigeminal. That's us. Got it? Very important. Dentists are in charge of the trigeminal system. Spend some time learning it. It's really important. But the mesencephalic nucleus, this is the area that does all this stereoscopic, where is my mandible at any given time. It's the one that senses where things are. And the mechanoreceptors on the periodontal ligament, when the teeth are functioning, it sends information there and it kind of determines where everything is. But now we're quieting everything down. So in an attempt to determine the position of the mandible, the mesencephalic nucleus allows the temporomandibular joint and the muscle proprioceptive information to dominate, and the mandible is therefore positioned to accommodate the joints and muscles, not the teeth, not the maximum intercuspation of the teeth. Got that? So before, basically, I wrote an article, The Killer Bite, meaning that the teeth have to interdigitate in the bite to kill and be effective. Got it? So if the bite is 3D off and causing joints to be damaged, then the mandible is going to stay in that bad bite area simply because it's efficient to bite immediately into place. Got it? So interdigitation of maximum intercuspation, interdigitation of teeth is a very important thing in order to function. The jaw rests right below it. Got it? All right, so part of that, the knowledge of where the mandible is through the periodontal ligaments. Now we're going to take out the periodontal ligaments by covering them with soft plastic, and now the brain is saying, mesencephalic nucleus, the brain, where is my jaw? Right? It has to use the available information, and it will use partly the muscles, because the muscles know where they are, and because there's proprioception in the muscles also. We forget that. Very important concept. And also, it's going to take information from the joint more. Now it's going to say, Lee, that joint, when it's in that position, the mandible's in this position. So it's starting to learn from other things rather than the periodontal ligament. Oh, we're going to start this slide out with a question. How does the soft decompression appliance work? And I call it decompression, taking away the compression. I feel like probably 90% of the time, 95% of the time, when the structures within the joint deteriorate, that the condyle goes backward into the retrodiscal tissues and creates irritation. And remember, the arthrokinetic reflex, that irritation is going to create havoc with the muscles. So again, how does the soft decompression appliance work? Well, by reducing the painful impingement, crushing in the back of the joint, or abnormal compression on the tissues inside the joint, by reducing the painful impingement on the highly sensitive retrodiscal TMJ tissues, and by reducing the overwhelming amount of nerve signals sent to the CNS. So we're denervating the lower teeth. That's now we don't have that information coming in, and then when we're stopping the crushing of the tissues inside the joint. Now, again, the soft guard is not a precise positioner. The soft guard is just pulls the joint down and forward slightly, and it opens the spaces and decreases the impingement. The hard guard does a much better job of that, absolutely, and does more things than that. But this is a intervention appliance, which we use initially, and there are definitely certain times when this soft appliance is the treatment of choice for the actual problem, and we'll talk about that later. But again, how does the soft decompression appliance work? By reducing the painful impingement on the highly sensitive retrodiscal tissues, and they are really sensitive, and by reducing the overwhelming amount of nerve signals sent to the CNS. There's lots of CNS noise. And then where's that coming from? From secondary to the occlusal disharmony. So almost always, not always, but almost always, there is a bite problem. But the bite problem comes from, the muscle problem. and we'll get into that. So secondary to the occlusal disharmony, so then the mandible is invited to posture in its optimum temporomandibular joint position, not off of the retrodiscal tissues. So basically, well, we no longer have to bite in our maximum cuspation because we don't know where the maximum cuspation is. So how are we gonna position our jaw? Oh my Lord, the CNS is fighting with this issue. And it says, okay, well, we do have the joint now, so let's figure out from the joint where we want to position it. And you'll almost always see with time that the open-closing rotation is different from previously. Because previously it was dictated by maximum intercuspation, right? The nature, evolution has caused us to rest right below maximum intercuspation. Now we put this soft guard in, we no longer know where maximum intercuspation is. We don't know where to posture and position our jaw at rest. So now it's going to go based on the joints, because it's going to say, okay, well, the joint is compressing back. It's a little bit painful. Let's move the jaw forward. All right, let's move it down just a little bit. Oh yeah, there's no pain in the joint anymore. This is where we want to put the jaw. And it's taking away maximum intercuspation and the periodontal information. Got it? Again, this is because the temporomandibular joint becomes the only source of proprioceptive information. And it isn't really. The muscles do that also. The ligaments do that also. The tendons do that also. But it changes to a priority where the TMD, the arthrokinetic reflex, becomes extremely important when you take away the maximum intercuspation information. Unfortunately, a lot of experts believe that it's bull pee-pee, that basically soft guard, well, soft appliances, they don't work, and you're going to get some authority saying that, oh, they don't work. And honestly, it's how you use them that works, and that you need to know what you're doing, when to use them, when not to use them, and what other things need to be done in addition to using them, you see? Because we're dealing with a multi-system human being. And to think simply, oh my God, I will never use this soft appliance ever because I don't believe in soft appliances. Oh, that's a bigot, not a bigot. That's a person that they already believe certain things. They're very prejudiced and they don't look. And that's not a scientist, right? And half of the time, many doctors, they'll put their appliance in, they'll make one adjustment, and they never see the patient again. They'll put, and that's criminal. I think it's criminal, right? I really do. So the use of soft TMD appliances, we have several papers here that prove that they are effective very often. So again, the first one is occlusal splint therapy or soft therapy has better long-term results in reducing the symptoms of myofascial pain dysfunction syndrome. It has better patient compliance. They're easier to use, fewer side effects, and it's more cost effective than pharmacotherapy. I hate meds because most of the time there's a strain, some sort of problem that you need to solve with a joint. Instead, you're giving them medicine. Botox is just a good example of that. So the muscles are trying to prevent the damage of the joint by contracting more than they should. They become tender and painful because of the job they're doing. It's not the job they're supposed to do. And you come in and you put Botox in, and oh my God, now the joint starts having problems. So hence, it can be chosen for the treatment of patients with myofascial pain dysfunction syndrome. It's an old term. So, and that paper is Soft Occlusal Splint Therapy in the Management of Myofascial Pain Dysfunction Syndrome, a follow-up study, and it comes from Pain, the Indian follow-up study in pain. Second paper, analysis of the results indicate that patient category treated with soft stabilization splints for longer periods of time show improved treatment, and the patients are more relieved and willing to continue the treatment than those treated with hard splints. All right, and this is comparing the stabilization appliance. And the stabilization appliance is a dangerous appliance. You know, there was a Cochrane report which all the dentists in the United States went crazy when the Cochrane report came out, and they said, well, excuse me, it works. I use it every day. And so they withdrew the Cochrane report, and I think it's probably a unique thing ever, right, that a Cochrane report would be removed. But Cochrane reports are the standard of evidence-based medicine. But anyhow, any appliance that's used improperly is going to cause damage. Got it? If you have a sleep apnea patient and you put a stabilization appliance in, that thing very often will cause a rotation backward with the tongue in the throat and make the apnea worse. So you got to know what you're doing. You can't just, oh, I use the same appliance every single patient. It doesn't matter what kind of patient it is, every single patient gets the same treatment. Well, that's the problem with diagnosis, isn't it? That you're not thinking. You're just using it all the time. And I always have a bad joke. You got an OBGYN that does an incredibly good hysterectomy, and he just recommends it on everyone. Then that is crazy as heck, isn't it? It's bat crazy. And that's what happens very often with dentists. Again, a third study, efficacy of the soft occlusal splint therapy and management of the temporomandibular disorders. And next one, a randomized clinical trial of intraoral splints and palliative treatment of the masticatory muscle pain. And then finally, pain release splint, which was published in Cranial Clinics International. So soft appliances do work. You have to know when to use them, how to use them, why to use them, and that's what we're getting into. But you should never say, oh, I don't believe in that. Absolutely, I don't believe in soft appliances. Excuse me, that means that you've never read anything. You've not been a scientist. You need to look at everything. So again, we're going to go through some of the things related to the mandibular decompression guard, soft appliance. Why are we using it on the lower, and why are we using soft? Okay. So let's talk about covering the maxilla. The maxilla interferes with speech, right? You've got something in the palate, the tongue's supposed to rest up there. That's not good. Covering the maxilla interferes with swallowing because as people, we swallow 1 or twice per minute and the tongue goes up on the palate and it compresses back, right? All throughout, we're swallowing our spit to keep everything nice and moist. So covering the maxilla interferes with swallowing. And plus you can see it, like covering the maxilla interferes with aesthetics. So people smile and they see this football guard or something and they don't like it. So there are 3 reasons that we use the mandibular decompression on the bottom. You can occasionally do an upper, right? There are exceptions to all rules, but primarily we're going to be using a mandibular decompression soft guard. Next thing is osteopaths, a DO, doctor of osteopathy. they have full medical privileges, at least in Georgia, and they have a science which is totally different from what we think about. So the cranial bones, they actually move, and there's laser evidence of this, lots of studies, but we don't think about it at all as dentists. But osteopaths believe that the maxilla must flex and move for optimum health and pituitary function. And if you look at the lines of forces of teeth, there's a diagram, I think Monson, I don't remember, but you've got the angulation of each one of the maxillary teeth, and then you make lines going forward and upward, inward and upward, and guess where they converge? At the pituitary seat, sella turcica. Crazy, but just lots of stuff to think about, that there are other knowledge bases that believe in certain things related to what we do, and we very often will poo-poo them because we don't understand them, but it's very important that we look at the entire human being and all the different systems involved. So I choose the mandible whenever possible to make appliances on, because let's say even if you didn't believe, you say, well, let's assume that the pituitary doesn't dysfunction related to maxilla function. All right, so by putting it on the bottom, I'm not affecting anything anyhow. But if it does, I'm helping it. So osteopaths believe that the maxilla must flex and move for optimum health and pituitary function. And this is their science, right? Maxillary appliances interfere with this function. Constructing a mandibular soft, vacuum-formed appliance is easier than a maxillary one because we cut out that middle and the suck down is easier. When you keep the palate, it's harder. Typically, dentists use the entire palate to support a soft guard. And when we're doing a mandible, we can't put it in the middle, the tongue is in the middle. So it's easier to do a vacuum form on the mandible. So constructing a mandibular soft vacuum form appliance is easier than a maxillary one, since the area between the teeth is open and allows for better suck down. And that has to do with the construction of the soft guard in the lab. And you can teach your staff to make these appliances also. They become incredibly easy to do. They become an income resource. Isn't that nice? Plus, it's pleasurable when people come back and they're just really happy. So there you go. All right, so I believe that the human being is a multi-system organism. And then remember the paper I said earlier that Frickton stole it, or maybe he did, but Laszlo Schwartz talks about muscle pain in the early 50s, right, as being a primary source of chief complaints for TMD patients. And Laszlo Schwartz wrote a book also in that area, and he's just an old guy, right? And I try to read as much as I can from old guys and their wisdom. And anyhow, one of the things that I did in the late 80s was develop a 6-week TMD program for my patients that is absolutely necessary, absolutely with every single soft guard. Please listen to me. Don't ignore this. Don't be crazy. Do everything that you can. This only involves a handout to the patients. Have your assistants learn how to administer this program. It's easy to do. It gives value also to the visits when you're coming in. It gives your staff something to interact with the patients with, and it helps patients. But most of this 6-week program is aimed at eliminating muscle pain by improving muscle health. Got it? Muscle health. I sat down and said, what causes muscle problems? Oh my God, what can I eliminate? What makes muscles happy and healthy? Well, what can I add? And I sat and did this program. And this was in '89, all right? So all of the information being presented about the 6-week TMD program is reviewed in the Adobe Portable Document PDF 6-week TMD program handbook, which is included as part of the TMD, the basics course. So if you wish to get this portable document, I'm happy to give it to you. I also made a video just on the 6-week program that you can look at the Atlanta TMD Institute. Right now it's on our YouTube video, so sequence playlist. You do not need to take notes for this section of the course, so please carefully listen and attentively watch, since paying close attention will better help you understand the handbook and thereby more correctly treat your patients. And I hate telling you that there's a handbook, because you'll say, oh, I don't need to learn this. I want you to pay attention while I'm teaching, because I want you to be a Buddha dentist. I want you to have full knowledge of things and understand what's happening. But again, it's a PDF, and there's also a video on the 6-week program. The 6-week program is absolutely part of the Soft Guard. Please, always, even when I'm making it for non-TMD patients, it's a 6-week program. So we're going to go through the different visits and why we do certain things and what you should do during each visit. Of course, you can modify anything you want. So the first thing, absolutely, is the patient signs a TMD informed consent form, and we have that also. We are in a medical legal situation. Let me tell you, a lot of people believe that TMD patients are crazy, and there is a certain amount of craziness in the TMD population. They don't sleep well. They don't have REM sleep. That's how the Russians tortured we waterboarded, they denied sleep. There's just you can drive people crazy doing that, and there's a good segment of people who are crazy for various reasons, and that very often you'll get rid of the craziness by treating them appropriately. But irregardless, you can get sued, right? Or they'll say, give me all my money back, you're an idiot. And you're looking at this patient, you love them, you want to hug them, you want them to be healthy, and they're being really antagonistic towards you. So, I have one patient I got to share with you, sent over by a periodontist many years ago. And the girl was curled up in my operatory 2 chair, curled up in a fetal position, crying. And so I come in, and she's just in terrible pain everywhere. And so we, made an emergency soft guard. We went through her treatment. We did everything incredibly well. And not only that, the clothes she was wearing changed, bright stuff. She was taking care of her hair and wearing makeup. She was hitting on my male assistant, everything. At the end of the 6 months, this person who was called up in pain and couldn't function and crying in such pain, got nasty with me and said, you were supposed to fix the way this cuspid here hits. She put her finger on it. And I'm like, oh my God, this had nothing to do with her, but she just got nasty, and she turned around, talked to the periodontist who referred her, gave me a negative report, and he doesn't refer to me anymore, but she is crazy as sin, because I should have took video, and I did have an informed consent, but it's a no-win situation, and everything has to be documented well. So the first thing, absolutely, we're in a medical legal situation. We're establishing a relationship with a patient. It is a medical legal one. We are not their friends. We're their business associates. So the patient signs a TMD informed consent form. A knowledgeable TMD assistant takes an oral history and fills out the initial portion of the TMD exam form. Now you can substitute the oral history with a informational form that the patient fills out if you want, but I like, you can teach them to sit and ask basic questions, and I do like it. I build into my fee the amount of time that the assistant is one-on-one with the patient, just asking basic questions. Basically, if the assistant is filling out a form, by asking the patient the information, which is very personable and one-on-one, rather than having the patient fill it out. The dentist performs a brief, could be 10-minute screening exam, while the TMD assistant documents the dentist's findings. Now, this is with a person who has very minor problems. Again, minor problems, right? I use a TMD appliance. I use a soft appliance on all my TMD patients, all of them. So I do a very extensive half-hour examination with a cranial nerve exam in detail. But if this is just a bruxism patient or a minor MPD patient, myofascial pain dysfunction syndrome patient, mostly muscles, you can choose this. But again, I think it is very good to establish a relationship with your assistant and the patient. Everything is documented. Why? But you're proving that the patient needed this, and you're not trying to make money like a very bad, filthy person who wants to make money on people. No, patients need this, so you document it to show they needed it. You also document what is the problem that they're presenting with. So later when they accuse you, you're going to say, well, listen, you couldn't open. That was the number one thing that you had. Now you're opening fine. Now you're complaining about clicking, but you couldn't open when you first came in, or whatever it might be. And then in state of Georgia, an expanded duty dental assistant can take a prosthodontic level alginate impression, right? Prosthodontic meaning a really excellent impression. And now we have scanners, right? 3D scanners, which can print these things out. That is really nice too. And that can be done. So instead of an impression, you could scan it and then print it out. But again, these steps, the knowledgeable TMD assistant reviews and completes the TMD exam form, but you have to go in as a dentist and confirm with your findings, because you're the one making the diagnosis, not the assistants. The assistants work with you, collect the information with you, interact with you, much like a PA, physician's assistant, would interact with a physician. And so all these things are done at the first visit. So step one is done primarily by the assistant. We do that because the system is an independent witness. You should never witness your own informed consents because you have a motivation to lie in court. If you say, well, yeah, I saw her sign this, you can't sue me. Well, it's better to get a third-party witness, which is your assistant. So again, step one, print out and carefully review the SoftGuard informed consent form with the patient. Now remember, we want the patient to know the rules. Here we go. Here are the rules. And it's extremely important that you read this SoftGuard informed consent so you understand what you're promising. And the patient needs to know what the agreement is and what you're trying to do with the SoftGuard. The patient is asked to sign as the dental assistant watches the patient signing, and the dental assistant then signs as a witness. So we have an independent third-party person who's not making or losing money if you go to court, and that person could say, yeah, I saw her sign it. Because the patient could later say, you did not explain that to me. The dental assistant then electronically scans the signed document and places the paper consent in the patient's chart. But a lot of things have changed since I first wrote this out. We have electronic stuff, and we were using a company called NLive, and unfortunately, NLive did not automatically upload documents into the patient's document center. So we lost a number of these signed forms. So I don't know, I keep on going back to basic stuff like having actual paper informed consents, because I think it's really important. During my career, I spent almost 25 years as a dental expert witness. I worked with like CNA and some other companies, and I have seen some crazy stuff. Let me tell you, I've seen dentists get off of things they should have been convicted, and then other things dentists should not have been sued, but yet they ended up losing. So it's so crazy. But just remember, we have a medical legal relationship with patients. They're not our friends or family. And even with family, we get into arguments. And you need to make sure that this consent form is signed before you begin any treatment. And if the patient refuses to sign the form, you should refuse to treat the patient. This is probably the most important step, even though we're not taught in dental school that these things are important. They hardly ever even teach them. We're just learning to do things. But I think it's extremely important to establish right from the beginning what you're providing to the patient so that the patient cannot later accuse you of failing to do something absolutely necessary that they believe is absolutely necessary. So the first step is to print out and carefully review the soft guard informed consent form with the patient. The patient is asked to sign as the dental assistant watches the patient signing, and the dental assistant then signs as a witness. The dental assistant then electronically scans the signed document and places the paper consent in the patient's chart. So we need a permanent, absolutely need, and I wouldn't continue any treatment. This is the best advice I could give you in this whole course. If the patient refuses to agree to the program and sign the informed consent, the money you're getting is not worth it. Don't continue. Don't continue at all. It'll just be a thorn in your side. TMD patients tend to be pretty emotional, difficult management people. They sue people more often than regular patients. You know, they may not have had a night's sleep in 2 to 5 years. They may be REM sleep deprived. They may have metabolic syndrome with a lot of achiness and pain and all kind of stuff. You really need to get this consent form signed, particularly since this is an introductory trial, TRIAL treatment. The soft guard will resolve, in my estimation, about 50% of most cases. So in other words, we place a soft guard, we put them in the program, and when a patient complies well, half of those patients come in improved in a week. Now, that is not the objective that I want, because I'm a specialist and I see all the various problems that we have when we don't fully treat. However, simple cases can be treated with a soft guard initially, and it's a screening device, okay? It's a screening device. But there must be a signed consent form which outlines, and you need to read it and understand it, because you know, if you go to court later, you're going to have to know this consent form. Got it? If you're reported to the Board of Dentistry, you need to know what's in this consent form, because it documents and proves the situation that you are providing to the patient. So always, always, always ensure that the consent form is done before you start. Sometimes I used to very often trust my staff members, and even though I've trained them and they're not supposed to, I'm not supposed to take any impressions on anybody without a consent form, sometimes there's just problems. And honestly, you must get a consent form before you sign, and I think you should take an interest in absolutely ensuring that this soft guard consent form is signed before you start. So once you have completed your exam and all your documentation, and you have the patient sign the consent form, and only after you've confirmed the consent form is signed, you never do any TMD treatment without a consent form. Please don't do that. That's just dangerous as hell. So anyhow, step 2, the expanded duty dental assistant in Georgia. A expanded duty dental assistant can take a soft guard impression, a mandibular, without you ever being in there. Isn't that nice? So whenever you can delegate, you should delegate. This makes your office more efficient and more profitable and more pleasurable ultimately, both for you and for the assistant who now has important duties. But step 2, the expanded duty dental assistant or dentist then takes a prosthodontic level excellent mandibular alginate impression. I love these things. I've been doing impressions, I don't know, since like 78. And it's just, this is what I do. I'm used to it. And so I use this. We recently bought a scanner, and 3D scanner, and I think it's going to work out really well, but I haven't got to the point, I'm using what I'm used to, what I like doing, what I do well, right? What's the reason to change? I do want to change, and I see a lot of benefits with the scanner because the scanner could do all the trimming and print it out while you're doing an exam. You can modify your the steps one after the other, but for whatever reason, right now we're taking alginate impressions and we're doing really good ones. Step 3, air dry the alginate impression, make sure there's no water in there, and immediately pour up the alginate impression with dye stone, specifically for constructing the decompression appliance. So you're not going to put a base on this because you're doing a suck down. You want the center portion to be open. Dye stone doesn't break easily, so when you're removing the dye stone model of the patient from the alginate, it's not going to break as easily as if it was dent stone or plaster. So we use dye stone. This is a very common company. The product, Modern Materials, they make dye keying green, but I buy generic also, so much more inexpensive. But this is a very good product. But again, do not throw the alginate away after moving it from the master dye stone cast, because sometimes you might need that alginate. But again, dye keying. And if you're scanning, you're doing it on a resin, so that's maybe even better because there's less chance that a resin will break. But we use dye stone on our impression. We pour it up immediately. Alginate needs to be done immediately, and we take it out within an hour while the alginate's soft, so less chance of breaking. And we pour it up so it's a U shape with no base, so that we can almost immediately just do quick trimming and then do a vacuum form suck down of the material for the soft guard. So here we have a lower mandibular stone model. Step 4 is remove the mandibular dye stone model in 1 hour because you don't want the alginate to dry out. There's more chance it will break. And trim the excess areas off of the model specifically for vacuum former use. And again, when you look at this model, the right second molar doesn't look as good as it could be. I don't know what happened there. We've got some alginate in between we can clean out. That's important because we want the suck down to integrate onto the teeth as closely as possible, so there'll be retention. We're going to cut the backs off of this very close. If you look, we need teeth on the suck down. We're not doing a suck down on soft tissue. So we're going to have to cut the back of this off from the bottom up. You see this patient has tori. The left is greater than the right. See this asymmetry, guys? Asymmetry. Tori are buttresses. Tori come from grinding. Tori are an engineering marvel because you have the lines of force, the trabeculi, right through that tori. And we know that the patient is grinding more on the left. The tori are bigger. And you see the very flattened left cuspid. Right's flattened too, but left looks worse. Got it? So whatever it is, so we want to trim this down to get some of this middle out and the sides off. So when we do the suck down, it'll be it'll fit beautiful, and the suction will be greater. So here the assistant is trimming it close to we don't want to cut the teeth off. Don't touch the teeth ever. And whether you're using it with a scanner and you're scanning how you're cutting, this is a Ray Foster model trimmer, and it's connected up. It's a dryless one, and you'll see that the bottom of this cast on the left is flat, right? Because that goes onto the vacuum form machine, beautiful, on the table, and we're cutting any extra stuff off. The heights of contour are marked with pencil there also. So generally I will cut below the heights of contour to accentuate that undercut because I want the soft guard to lock into that. This is a very important concept. So heights of contour are drawn, then we use a wax carver to carve underneath the lines of contour. So you want the soft guard to snap on, so the bottom part will snap over the heights of contour and lock underneath. Remember, this is a flexible material. Well, when you're using acrylic, you can't do this, but you can take the material to create undercuts, more dramatic undercuts, so that this soft guard material, which is soft, will flip over and lock on. It'll lock in the interproximals. It will lock below the heights of contour and hopefully fit beautiful. And so I marked the heights of contour with a pencil. So step 5, mark the facial and lingual heights of contour on the posterior mandibular teeth and carefully relieve the area below the heights of contour and above the gingival line. Remember, teeth don't hurt. When the soft guard snaps over the heights of contour and then presses on the tooth, there's no pain because teeth don't hurt when you press on them. Got it? You don't want to carve the gingiva at all because the gingiva, if you press on the gingiva, it's going to hurt. So we are just relieving the area underneath the heights of contour. So when we do the suck down, it's going to be really snapping over that and push hard against the area, undercut area. So you can see how I'm scraping with a half Hollenbeck wax carver underneath the heights of contour. So I'm actually making the tooth smaller slightly than the real tooth because I want that to really snap in neat and tight. So when the patient puts the soft guard in, ideally I want it to snap in and be resistant so it won't come up. So when the patient takes to take it out, there's a certain amount of resistance. Remember, this is important. The patient is wearing it 24/7 initially, and so you want it to stay in place without the tongue whacking it off, right? We want it to be locking underneath the undercuts, and so we're accentuating the undercuts or deepening the undercuts. All right, so step 6, you place a 0.16 inch sheet of soft thermoplastic material in the movable holder. You'll look at so we got the vacuum forming machine over to the left, and you'll see there's 2 handles in the middle to the right, and those 2 handles are open the holder, and you put the thermoplastic material in evenly and you lock it down. All right, so place a 0.16 inch sheet of thermoplastic material in the movable holder of the dental vacuum forming machine. Be careful to clamp the edges of the material between the clamping plates. And that if you look at 2 handles, it opens and closes, and you'll learn how to do this. Most offices have a vacuum forming machine because we do whitening. You can do whitening trays with this, or you could do TMD soft guards, right? Same process, very similar, and the material is not that expensive. Long history here. I used to buy my thermoplastic material from a company in Vermont, and it was very inexpensive. It was like $10 for 12 sheets, and then a major gobbling up dental company came in and purchased it, and immediately raised the price from like $10 to like $28 for the same product. It was just really crazy, and that's how they made back their money. But still, I shouldn't be arguing whether it costs $1 or $3 for the thermoplastic material. It's a minor expense relative to the total cost that you're charging the patient. But I buy the large Keystone boxes, university boxes of these things, because I make them all the time, right? And I think it's almost indefinite length of time that these last. They don't really have an expiration. But anyhow, you're putting it into, you got your thermoplastic machine. There's a little button on the bottom, and when you go to the left, it starts the heater up on the top. When you go to the right, the suction occurs. And you'll learn how to do this rather easily later. But again, the first step is to get the correct thermoplastic material and place it in the clamp, right? And then you're going to bring it upward.
Hi, my name is Tori from Keystone Industries, and today I want to talk about the powerful and highly recommended US-made Machine 3. It has more power than any other vacuum former, which means it's producing more accurate and stable results. What once required a lab is now being completed in-house at a dentist's office thanks to this machine. To see how simple the vacuum forming process is with the Machine 3, keep watching. This is the material plate where the thermoplastic material is placed and then locked securely. The plate can easily be adjusted up and down. Once the material is secured, raise it and then bring the heating element to the front. From here, you will wait for the material to heat. You will know that it's ready when you see an 1.5 inch droop in the material and by checking to see if it's tacky. Once it's ready, turn on the vacuum, swivel the heating element, and bring the material down to suction. You can aid in the cooling process by using Keystone's InstaCool. And prior to removing the model, be sure that the material has cooled. It's that simple. To learn more about the Machine 3, instructions for its use, and how it adds value to your practice, visit KeystoneIndustries.com. Thanks for watching on this great day to be in the know.
So here's the suck down material sucked over the prepared model. It says step 11, place the warm suck down in a laboratory pan or on a counter and allow the thermoplastic material, which is hot, to completely cool down. It shrink wraps to room temperature until the next day. Now this is something really interesting. It takes a few hours for it to fully cool, but it just, when you look at the product, you look at the actual suck down, if it's been left for a day, it has fine little details in the teeth in the suck down because evidently it does take quite a bit of time for it to completely cool. In other words, 3, 4, 5 hours. So I prefer to allow it to sit for a day. And we're looking down on it, and you can see I have a black line all the way around the edge. You use a regular dollar store scissors and cut all the way around the edge and throw away the excess. Then we use a crown and collar scissors and cut straight down the middle of the center where the black vertical line is. And we're just preparing it so we can get the model out without busting it. If you're doing full TMD treatment on this patient, you'd like to conserve the model so that you can use it for the construction of the MORA. So you want to remove this thermoplastic material after it's cooled the next day as gently as possible. You want to make multiple cuts around that plastic without touching the teeth so you can kind of make it more flexible so it can be removed without destroying the model. So here we're cutting the outside with a large dollar store scissors. Step 12, using a large traditional scissors, cut all of the surrounding excess 0.16 thermoplastic material away. You're just going to cover it right off so you'll have the thermoplastic only on the model and the center portion. All right, you've got all the excess out and around the model cut away. Step 13, and it's using a straight crown and collar scissors, cut a center line down the middle of the model. So we're trying to make these cuts so we can get access to cutting the edges and make the thermoplastic material more flexible so we can get it off of the model without destroying the model. So there is technique to this. And even though it seems like, this is boring, you don't want to bust models. So you're looking at the side, and I'm using the straight crown and collar scissors to cut straight lines up to just below the teeth. Remember now, the soft guard goes on teeth, maybe just a itty bitty on the gum, but we cut away the area around where the gums are so that the thermoplastic material doesn't press on the gingiva. But I'm making these vertical cuts, so I'm teasing the plastic out a little bit, putting the scissors in vertically and cutting up. So step 14, using a straight crown and collar scissors, cut straight lines up to below the teeth on the sides of the die stone model. Take your time. Don't use a lot of force. All right, so step 15 is gently remove the die stone model from the thermoplastic suck down and using a straight and curved crown and collar scissors. And again, we'll stop here for a minute. You see how you got the vertical cuts? And there's no model in there anymore. I was able to get the model out. And I've got a black line showing approximately where I want the excess material below cut off. So here's an anterior view. Again, we have this horizontal line. It's below the teeth. We want the guard to end close to the gingival margins on the facial of the teeth, but we don't want it extending down on the gum very much because it will irritate the gum, and patients will say, oh, my frenum's irritated, or they'll say, oh, my gum's irritated. So we cut close to the teeth, and then when we're doing our finishing, we try to bevel, very slight rounded bevel, the inside that's touching the gum so it won't touch the gum, pull away from the gum, not irritate the gum. All right, so here we've cut all the excess inferior away, and it's ready to be finished now. So you can also see the height of contour markings where we cut a little bit off, it snaps in. And it looks pretty good at this point. The most common place that we tend to have problems, however, is at the very back and back of the second molars or third molars. I tend to overcorrect and cut away excess amount there because the most problematic place where people come back after a week and say, oh, it hurts, is distal to the last molar, which is typically second molar, sometimes third, but that you want that curved in and cleaned. But there you go. So we're going to move into the finishing of the soft guard, and it's kind of a critical aspect. We forget when we delve into theory how interesting theory can be, but ultimately, practically, we're making an appliance that a patient is going to wear, and we want it to be as comfortable as possible, not irritate the cheeks or the gums, and so it needs to be very smooth and highly polished. And the dental lathe here, handler lathe, makes quick business of finishing a soft guard. It really does. You can use other types of ways of finishing, and we've done that, but this tends to be the very best way. So purchase a lathe if you don't have one, and you're going to use a conical sharp acrylic lathe burr on the right side. On the left, you're going to use a muslin finishing towel disc. So you have to remember that, we can talk and talk and talk, but ultimately clinical success is important, and you don't want to have any hindrances to clinical success. You always remember that the soft guard is going to be worn full time, 24/7 other than eating, by the patient. So we want it to be very comfortable. The most common area of disturbance from patients or complaints from patients is the sharp edges pressing on the gum tissue. So we want everything to be very smooth and rounded and polished and not irritate tissue whatsoever. When you cut the soft guard, you look at the left hand vertical diagram, says soft guard, there's two very sharp edges from cutting with the scissors. And your goal is to physically use a burr to take those edges off and round them. You're basically rotating the edges of the soft appliance while you're cutting, and you get what I call a rough trim. And so here in the middle one, we're using an LOH laboratory burr, and we use that. That's what we used to do. I used to do this all the time, and it didn't take very long to finish the soft guard, but using the lathe really makes it so much easier and better than with the motor, the laboratory motor. So the soft guard, you take the edge off the right edge and the left edge, and you're rotating the LO4. Now with the laboratory lathe, you're doing the same exact thing. You're rotating the soft guard edges and moving them continually so it doesn't cut in order to round it to get to the far right vertical diagram where the bottom edges of the soft guard are curved in. And this is a rough trim. And again, the LO4 laboratory burr, we use that on all our hard guard adjustments later, you'll see, and we use the LO4 to make clinical adjustments on the soft guard. So you do want to get to use that LO4. LO4 is just a very nice HB handpiece burr that we use in the operatories to adjust the occlusion of the MORA, which we talk about later. We also use it to adjust the soft guard. The end of the LO4 here is not actually accurate. It's actually flat. And but again, remember, you can use the LO4, but most preferably you want to use the dental lathe with a sharp acrylic trimming burr. So here we have a lathe with both sides having the muslin discs. And again, you know, I pull muslin disc on and off, and of course for cleanliness reasons, I'm always changing them between patients. But we have the muslin disc with protective metal enclosures on each side. Always use glasses when you are trimming the soft guard. Yes, I have got pieces of acrylic in my eye before, and I had to go to ophthalmologist to remove it. So use laboratory glasses always in order to protect your eyes while you're finishing. But the next to final finishing, and really all you have to do is use this muslin disc with some fine pumice, and it just smooths the edges. So you've done the rough trim using a acrylic trimming burr on one side of the lathe. On the other side, you have a muslin disc that's wetted and has some fine pumice, and you're trimming and moving it. And that muslin disc puts a beautiful shine and smooth surface on the soft guard. Really does. So again, you can use the LO4 carbide burrs, HP, but again, I know I'm going back and forth, and you're like, why do you keep these slides in? And because we made them a number of years ago, and yeah, I did it for many years in the operatory, but now the lab is just so much better using the lathe. But you do want to get used to these LO4s because they're like workhorses, and you can buy them rather cheaply from eBay, like a dozen for a buck, buck and a half each, and they last forever until you drop them on the floor and they warp and bend, and then it messes up your handpiece. But you can smooth the sharp edges with the LO4 or the lathe, and then polish with the lathe and the muslin, and finally go back with the chloroform back and forth with a 2x2 gauze. You wet the 2x2 with some chloroform, and it melts and polishes the edges of the soft guard. This isn't always even necessary, but if you just like want the ultimate, you can use the chloroform. Now this is a bottle of dental chloroform, but you can order chloroform online, like huge jugs of it, much cheaper than if they call it dental. As soon as they put the dental label on there, they increase the price 1,000%. But we buy the big jugs of chloroform, relatively inexpensive, and I think one big jug will last you 10 years. I have fallen in love with these laboratory motors. I get them on eBay. They're not very expensive. The handpieces, you can buy the whole unit, or you can buy the handpieces separately, which is really nice because when you bust your handpiece, you can replace just the handpiece. If you run that handpiece without a burr in it, it just locks up and ruins the handpiece. If you drop it, it will also ruin it. I like this particular design, the motor design, where it's all dark, thick plastic, and I just like it. But they're relatively inexpensive. I don't use the foot control. It's just another thing in the operatory that gets in the way, so I throw those away. I put the cradle on top of the Marathon, and then you have forward and reverse control, you have on and off control, and then you have the speed control. But these are so much better than using the very expensive air-driven handpieces that we use to do treatment on patients. And the Marathon unit itself, control unit, lasts like forever. It's very rare that those will break, but the handpieces do break, so I try to get a few of them. I buy them in bulk, so usually you can negotiate and get 3 of them with 15-20% off if you buy 3, just from eBay, believe it or not. But this I have one of these in every single operatory. I use it for my hard guard adjustments and soft guard adjustments, and you can use it clinically for temporary adjustments. And so it's a useful instrument and not very expensive.
So let's talk a bit now about basic finishing of the ProForm material, specifically the night guard in this application. You'll notice first off that the ProForm logo is directly placed where it needs to be, which is lingual to the anterior teeth, which gives that nice support that we were looking for. Here's the actual sheet itself. I've cut this material out. This is just a gross cut. You can use a hot knife, industrial scissors, carbides, whatever your preference is, but we want to basically get it to shape. Once we get it to shape, I like to take a product called the Z-burr. And the Z-burr is a carbide that's diamond. It is fluted, and it's run at slow speeds. And that's pretty critical as far as using carbides on these types of materials, because we used heat to form them, and we want to keep as much heat down as possible without generating, and so we do that by not generating friction. Friction's heat. So by using this carbide at a slower speed, about 7,000 RPMs, I find that it cuts extremely well and doesn't melt the material around the borders. I'm using a Handler Synchro Torque 3, works extremely well for this application. I've always been partial to micromotor handpieces just because of their ease of holding them, and I never got used to using a lathe. You could use a lathe, and you could also use the Z-burr in the lathe, but I just prefer to use it in the micromotor handpiece. With that being said, I'm going to turn this unit on, and then I'm going to show you the ease in which this Z-burr cuts through the material and the pre-finished state that it leaves the material in. So I'm going to turn the unit on, and then I'm going to begin to trim. You'll notice that it's flexible and it moves, so you want to keep the carbide as close to the support area, which would be my thumb. You'll notice my thumb is actually supporting the area, and we'll grind down. What we're going to do is we're going to rough shape this because for brevity, for time's sake, there'd be no sense in refining it, but I wanted to show you how nicely this Z-burr cuts the material, how it doesn't burn, doesn't leave any rolls, and at the same time it leaves a nice ultra smooth finish, which is to make it extremely easy for the final finishing of the mouth guard. This Z-burr is also a great application for things like light cured base plate material, soft liner removal, lots of other types of applications where heat and longevity of the cutting edges is desirable. And again, you'll notice how I'm supporting the material with my thumb. And again, it sometimes wants to get away from you, and that's why it's good to either hold it taut. You'll notice I'm holding it taut, or I'll brace it with my thumb. That's just a nice way of keeping the carbide in control, because all carbides want to run. They want to tend to grab and run on you, and you don't want that to occur. So by applying the thumb force and some stability, that keeps the carbide in order. Now, if you don't feel like it's cutting fast enough for you, you can try a little bit faster. This is 9,000 RPMs, but as you'll see, if you don't dial the speed in just right, it will start to melt the surface a little, and it doesn't cut nearly as well. You know, that old adage about more is better doesn't always go true, especially when we're talking about dental materials and applications of heat against certain materials. But as you can see, this cuts just extremely well. And again, I'm just going to rough shape it just to give you an idea of exactly how nicely it really does work and why it should be part of your armamentarium when you're using certain tools to trim and refine our prosthetics. Again, you'll notice, look at how nice it just cuts right through. It's like butter. And again, I work on this for an hour and you'd be bored of hearing me talk, but I want to just show you how nice it controls. See how nice that controls? And again, I'll do the other side as well. Hold it taunter. Notice as I hold it taut, how the material cuts easier. It won't deform, so don't worry about it. It goes right back to shape. But the nice part is that it just cuts extremely smooth and it's not burning. And if I wanted to, I could actually bring the heat down, bring it down just a little bit more as far as speed goes. This is about 6,000 RPMs, and again, I even get a smoother finish. I might have to apply a little bit more pressure to get it to cut, but it still accomplishes the same task. You know, we need to take our times on these kinds of things instead of racing through it, because taking our time will avoid the pitfalls of doing something wrong and having to redo the entire thing. So anyways, I've gone all the way around the periphery, and again, I just wanted to show you how nicely that cuts without really burning. Okay, now what I'm going to do is I'm going to change, and I'm going to substitute out mini Scotch-Brite wheels. These are Hatho mini Scotch-Brite wheels, and they work extremely well on these types of products. Actually, they work extremely well on all products, because they disintegrate at the same time that they're actually trimming. And the only pitfall on that, of course, is that you have to have an adequate way of removing the particles while you're trimming, because it's disintegrating itself while you're using it. And that's why I prefer to use the Handler Super Sucker for this application. So we'll start on the borders, and we'll start with the medium, what they call the medium grade of Scotch-Brite wheel. And the medium, it comes in 3 grades. It comes in a maroon, which is a fine grade. It comes in a black, which is your medium grade, and it comes in a brown, which is your coarser grade. What you want to try to do is try to run along the edge on the sides and on the top. I found that by coming acrosswise on the border, it tends to catch, and I don't want anything to fold or get caught under the turn of the wheel. So by taking and using it down the border, first on the edges, and then on the top, what it does is it imparts a very nice finish. And again, I would not be so concerned, and I think people are overly concerned about making this a glossy edge. It's not really that imperative that it's glossy, as long as it's smooth and isn't irritating. So again, as you'll notice, I'm using the same thumb technique to brace and hold the material in a taut, in a kind of a firm, supportive way, so that it's not running all over the place. And again, it allows me to control the discs, and they work extremely well. You'll notice that from time to time, see how I'm moving my finger back and forth? You get like a little groove in the top of the Scotch-Brite. You could stop the machine if you wanted. You could go back and you could true that out smooth again, but I don't find that it's a real issue. This is usually 1 or 2 and go. I'm going to throw this thing out when I get down to the metal hub, and once I chew it down a few times, I'll find that it's not usually worth anything at that point. It does get firmer. You could maybe use it for some other applications. I actually use it to pre-finish borders on dentures, as well as things like night guards and mouth guards and things of that nature. But the beauty is that I'm only running this at 6,000 RPMs, which is great, and it's still, as you can see, it's still cutting. Now it is disintegrating, and I would recommend, if you're going to be using these mini Scotch-Brite wheels, to double up on the protection. The vacuum's good, but I'd even use I'd use it like one of those mouth germ guards that they sell, for people. You see people on airplanes wearing them so they don't get sick, for infection control. But it works extremely well to cut. And I don't want to digress. Now I can cut the center out of here, but for time's sake, I'm just going to leave that out for the time being. But what I really want you to see is how nice that you can start to finish up these edges. Once you get it to this state, I usually go to the fine one. And this is the fine Scotch-Brite wheel. And I just go over this just gently, just to kind of get that nice, finished, smooth appearance. Again, don't be all worked up about this. Now, if you see this and it really bothers you, you could take a small blazer or some sort of butane torch, or even something that's less complicated, and use just a flame torch if you want. You may be able to flame that out so it smooths it up, but I've never found that to be an issue with the patients nor the doctors. As long as they fit well and are comfortable, is really where we're looking. The rest of it, the aesthetics, although we like to keep as aesthetic as possible, the fact of the matter is that that's not always possible. And I'll tell you the other thing. I really don't like subjecting these to heat, because we use heat to actually form them. And if you start subjecting heat to finish them by, glazing, polishing it with flame, it's just, to me, it's you're taking a chance that you'll deform the material. So I find that this is more than adequate. So, as you notice, the finished result here is that a nice, smooth, non-burned finish all the way around. It didn't take me all but just a few minutes. And again, if I wanted to finish it up with flame polishing, I could do so. I just don't prefer to, and like I say, I don't find that my clients nor their patients actually need to do that. Now, this technique is applicable to not only these mouthguard materials, but it's also applicable to the mouthguard, night guard, splints, coping. All of those types of materials work extremely well with these finishing products, because of the fact that it doesn't take much heat. There isn't much friction, and because of that, there's not a lot of heat, because there's not a lot of friction, and it's only 6,000 RPMs. And I set the handpiece at a set speed. I don't even use the foot piece, and it works extremely well.
kind of like planning everything out. I want all the staff to be on the same page. I want all the visits to be seamless without any disturbances, like the patients to be happy, and I hate when mistakes are made. That just are totally unavoidable. But the soft guard delivery appointment is primarily controlled by the assistant, the one that you train. You can almost make a separate appointment book and have a assistant in charge of that. And if you really get going, you can almost hire an assistant just for this stuff. So the soft guard delivery appointment is abbreviated Deliver Soft Guard, DSG. It's a half hour, but you could do an hour depending upon what you're paying your assistant. An hour would be nice if you want to show some video and develop more integrative one-on-one working with the dental assistant and the patient. This is a good thing for therapy to start developing relationships with the staff. Again, from a point of view of profit and just efficiency, it is just a wonderful thing to delegate responsibility for most of this appointment to a knowledgeable, caring dental assistant. And you should learn how to give up this responsibility. Now, before the patient arrives, several things have to be prepared for this soft guard delivery appointment. It is supervised again by a TMD assistant, and you should have the TMD assistant assigned to this particular appointment have everything ready. There needs to be someone responsible. So again, this particular slide says the things that are before the patient arrives. What are you going to do to prepare for the appointment? In other words, before you cook your dinner, you need to get everything needed for the dinner together in one place so it can be prepared, all right? And this delivery appointment should be prepared. There should be preparation, and it should be the assistant assigned. So the first thing is you place the completed finished soft guard, which has been polished, trimmed, in a laboratory pan. Laboratory pans are relatively inexpensive. You can store them hanging. There's lots of ways of storing laboratory pans. And then you pick out a colored retainer, orthodontic retainer box. We buy these again in bulk on eBay. I buy a lot of stuff from eBay because it's cheap. I go to the dental supply companies, and occasionally when we run out of things and we need to buy something, get it second day sent by a company that sells a dental supply company, I'm like amazed at how much I'm paying because of my stupidity of not doing a large stock. But place the completed soft guard in a laboratory pan with the patient's name and the appointment type and an orthodontic retainer box. You want to give the orthodontic retainer box to the patient and tell the patient when it's not in your mouth, it's in this retainer box, period. You include the original mandibular die stone model in the laboratory pan. Don't throw the mandibular die stone soft guard model away. Put it in the lab pan along with the finished soft guard and the orthodontic retainer box. Now, if this is only a soft guard program, let's say your hygienist picked up something, minor TMD problem, and the patient's pretty good, not having that bad a problem, then give the mandibular model, die stone model to the patient. Just let them keep it. You don't want to store things. I have been in offices where they've stored things for 40 years, and you're not going to believe it. I'm criminal to that also. We're in the process of destroying charts that go back 40 years, and I don't want to give them up. But it's best to keep an uncluttered office. And if it's only a TMD, if it's not really a serious TMD patient, you're just doing a soft guard program for grinding, bruxism, minor problems, tooth sensitivity, all right, give them the mandibular model to the patient, get it out of the office, and so that you can clean up the lab pan and use it for somebody else. If this is a full TMD case, though, and you're planning on putting a MORA in, that's different. You want to keep the mandibular die stone model in the pan, and we change the labels on the pan depending on what the next appointment is, right? So we're going to use that mandibular soft guard model later to make a mandibular orthopedic repositioning appliance, so we keep it in the pan. Now, this is before you print out a 6-week TMD program pamphlet and have it ready to give to the patient. This is already ready. You don't want the patient sitting there while you rush out of the room, come back 10 minutes later, rush out of the room, come back 10 minutes. That's just rude. It really is. But if you're going to do it, you got to do it. Isn't it nice? Patient's in the chair, and you got to go do something that's, finish the soft guard or get a retainer box because you were not really super competent, didn't get everything ready. Well, then you hand the 6-week program to the patient to read, and they're doing something useful while you're going around, scattering around, scampering around, doing things you should have done before. But again, please have all these things done before. And then before, a knowledgeable dental assistant, assign a knowledgeable dental assistant to review the 6-week program with the patient. Now, I like to come in and check the soft guard always with the patient. Part of that is establishing my doctor-patient relationship. Part of that also is legally checking the assistant's work. We're all human beings, and humans do better as a pack or a team, so we want to create that team. And so I do come in to these appointments. But you want a knowledgeable assistant who knows what they're doing to go over and review the 6-week program, how to clean and maintain the soft guard, how to keep that soft guard in the ortho retainer box when they're not using it. But you just want one specific employee, staff member. So now the patient's arrived and you've seated them immediately in the operatory where you're going to deliver it. I think everything's prepared really well, and this is not a long appointment, and you should plan on seating the patient right as soon as they arrive or right at their appointment. This is a good thing too. It encourages the patient to believe that you're an excellent practitioner because you don't waste their time, right? And many patients appreciate that. Of course, not everybody does, but we certainly want to spoil our patients. They're paying us a fee. Let's make their experience incredible, right? So that's why you do want to assign someone and get everything ready for this patient. So I have after the patient's arrived, which should probably be before, but you run your finger around the edges of the soft guard to be sure that the edges are rounded and smooth. And then the patient's seated, and you insert the soft guard in the patient's mouth. It should snap in. If it doesn't, it comes out in and out. You might want to deepen the undercuts and do another one for the patient. This is not an expensive thing. And then the patient thinks you're awesome because you're making them two, and then you seem like you really do care about them, and you do. So does the soft guard snap in, which means the undercuts were made nicely. And then you always, every single time, check the retromolar pad right in back of the last molar, second molar, or third molar for soft tissue impingement. We put it in and we say, is that pinching you anywhere? You look in there. And I almost always overcut the posterior aspect of the last molars because that's the number one area that, when we get complaints, that's the number one area. Number two area is lower front, where the frenum is interfered with. So these are the two areas that we check. And then we check the tissue, the gingival tissues below the teeth for tissue impingement. There should be no blanching of any of the tissue. Nothing should hurt when you insert it, and the anterior frenum should be free. And everything's smooth. And I always ask the patient, does this feel comfortable? And the patient says yes, I'll let them say, well, there's nowhere that it feels like it's pushing. And the patient says no, and then I'm out. But this should be done by the assistant right before I even come in, because my time is valuable. My support staff want to get paid well, and the way they get paid well is by making sure that I can earn income enough that I can pay them a very good wage, living wage. So this is the first rule that I have with soft guards. Dentists like to fiddle, they like to touch things. Um, I did a cosmetic course, I think, up in the University of Minnesota, and we had an opportunity to go to the 3M laboratory. And it was so interesting. One of the researchers said, oh yeah, when we do etching on enamel, it requires that the dentist wait for 1 minute, and dentists can't do that. They have to do something. So we have them move the acid etch around a little bit, because if we don't do that, they're going to mess something up. And I thought that was so interesting. But when you're putting in, you have to remember that if one muscle on one side of the mouth is shortened and tightened and the other side's normal, it's going to hit on the shortened side. So you don't want to cut away that side of the soft guard so they'll hit evenly, because you'll shorten it, and you're going to be building in the pathology. You don't want to do that, right? It's very important that you remember that there's asymmetries in the face, and then there are muscle contractions and tensions that are asymmetrical, and don't touch the soft guard on delivery. Patients go, oh, it's hitting over here, and your inclination is, you've got to do something. I have to do something about this. Well, that is actually stretching the pathological muscle, and that's what we want. When you get injured, what do? You stretch, and so we want to stretch that pathological muscle. Don't adjust the soft guard unless it's pinching some of the gum tissue. So don't touch the occlusion. So do not adjust the soft guard occlusion at the delivery appointment. It's usually that the muscles are shortened on one side, pulling the joint up and jamming the joint on that side, or the joint was irritated, causing the muscles on that side to shorten, and then so when they close, they hit that one side early, and you don't want to perpetuate that. You want to lengthen the muscles to their correct length on both sides. So again, just please take this as gospel. Do not adjust the soft guard occlusion at the delivery appointment, even if the patient's begging you to do so. So the deliver soft guard appointment basically is installing or placing, delivering the appliance, and also going over all the other details related to the program. Remember, the program is not simply a soft guard. You have to get away from being a carpenter and think more like a physician. Again, what do? You give the written, this is a pamphlet, it's written, it's a document for court. You need to keep it in the patient's chart. Please, you must give this. Don't just give verbal instructions. Give the 6-week TMD program pamphlet to the patient to bring home and study. And then I like the assistant to sit point by point. There's like 6 or 8 things that they do, and go over them verbally with the patient one-on-one and answer any questions. And again, this means that that assistant must know this pamphlet inside out and why we do each one of those things really well, so they can explain it to the patient or come and get you. Hopefully you will know, the dentist will know it really well. And we always schedule a 1-week soft guard follow-up appointment after delivery. This is critical because we want to evaluate the success. Don't assume that you're like so great and good that everything you do is wonderful. No, we want the patient to come back at 1 week. And every single patient comes back at 1 week so that we can compare all the patients that we treat at 1 week, because the symptoms at 1 week wearing the soft guard versus 6 week wearing the soft guard are different. So if they come at 2 weeks, it's different from 1 week, right? So we have them all come at 1 week. So you give the patient a written appointment card for this next POSG1, really, really important. So these are actually technical things that you're doing. You delivered the appliance, you're giving them a TMD pamphlet program, you're giving them a follow-up appointment, you have a written card, and then you're recording the patient in the patient's chart that you gave this written program to the patient. Very important. This is critical, because the patient has to comply, and they can say, well, I didn't understand. And you're like, oh, no. Yeah, we gave you written program. The assistant sat down with you. I answered any questions. We gave you plenty of opportunity to do well. Unfortunately, most people, I'm going to say most of these patients do extremely well at 1 week. Seriously, I would say 50% of the patients are amazed, and by 6 weeks they're all amazed. And I used to be amazed, and I used this as a primary appliance for many years until I realized there's much more to TMD than just relaxing muscles, right? There is, and that's why I'm cautioning you. This is, for some patients, the appliance to make, but for many patients, you have to go on and make a MORA, a mandibular orthopedic repositioning appliance, to align the mandible with the maxilla and the cranial base so that the neck will get better. Just lots of stuff that are required. I'm not poo-pooing this appliance. I think this appliance is very good. It's a great introductory appliance. We make it for every single TMD patient at the Institute. And so I want to encourage you, please get used to making it and managing it. It's a good appliance. And I'm going to say again, for minor cases, this is all that's going to be necessary. I just love notes, I guess, after being a dental expert for so many years. I think it's critical, particularly with TMD patients who later can forget things, that you do really good notes. So this is an example of what would be a good note, which is written by the dental assistant, signed by the doc for the Deliver Soft Guard appointment. Delivered the soft guard with written and oral instructions. The soft guard informed consent was previously signed, but the patient was again encouraged to ask questions. All questions were answered. The patient was given a soft guard follow-up appointment in 1 week. An appointment card reminder was given to the patient. Again, when you deliver it, you give the written notes. You could actually say the 6-week program. Oral instruction means that the assistant is talking verbally with the patient. We reiterate that soft guard informed consent was signed previously. It's really important. Just put it in there. The attorney will look at that and say, "Oh my God, my client signed this soft guard informed consent." All questions were answered, showing that, the patient says, I didn't know. And here you are, you're saying, oh yeah, we asked you if you had any questions, and we answered all the ones that you had. And the patient was given a soft guard follow-up appointment in 1 week. So they can later claim that I didn't have an appointment. That happens too. You ever see lawsuits? Well, the dentist abandoned me. No, there was no appointment. I didn't have an appointment and here you are, you put it in 1 week and they don't show up, and it shows, that you were competent and caring. They're the ones that destroyed the program. So again, you put it in there. And I always like an appointment card reminder. The reason being, patients sometimes, it doesn't happen often, but a couple times a year, someone walks in without an appointment and they get mad, and they said, they'll even name the assistant, this particular person gave me an appointment. And then in many instances, they pull the card out and it shows the patient, oh my God, you're a week early, or you're on the wrong day, or whatever it might be. So good documentation is very important. This is just an example of what the documentation should be like. You can be more extensive. That's great. Just make sure every appointment is documented with notes. We require all of our soft guard patients to come back in 1 week, and this is the POSG, post-op soft guard 1 appointment. That's the abbreviation. It's very important to start thinking more like a dental physician than a dentist technician. So we really want to be sure that the patient is complying with our instructions. Physicians know that patient compliance is probably the #1 hindrance in terms of patients getting better. How often do people say, oh, I've got some extra penicillin that I didn't use because they didn't comply with the physician's orders to take the entire prescription and wipe out the bacteria. But they always come back in 1 week, and there are very specific things that are done. All right, so you have the patient fill out and sign a TMD patient self-evaluation form. And this form is used with the Mandibular Orthopedic Repositioning Appliance, which is the real treatment appliance. It's used for soft guards. You know, you have to assess what's going on with the patient and find out early if there are problems, not wait to be loaded all of a sudden dramatically at some blow up. So please have the patient fill this TMD patient self-evaluation form out. They can fill this out in the waiting room, but it always accompanies the patient. When you're seeing the patient, you have to get used to this. It's very important. You're now a scientist. You're now applying your bachelor's scientific degree to taking care of patients, and it's a little different from dentistry. So after seeing the patient, the dental assistant takes range of motion measurements and performs a careful oral interview based on the POSG1 examination form while filling out this form. Now, it's very important that we take range of motion measurements. They're one of the absolute clinical indications of health. It's also something that we measure. And I think Lord Kelvin said, if you don't measure it, it's not science. So I'm not really sure that absolute quote, but it's a very important quote. We want to measure and assess the patient every time the patient comes in. The oral interview is done by the assistant, and there is an actual whole thing, a form that related to that interview, and it's basically indicating whether the patient has complied with the program. And the program includes not just the soft guard. See, we're dentists, we like put a denture in, and we're getting paid to do the denture. Well, excuse me, the soft guard is only part of the program. We know that muscles are 90% of the chief complaint of patients. We see that over and over again in all the literature, and we're treating the muscles in order to get them healthy. At the same time, we're using the soft guard. We're throwing the whole works at the patient, and we want to see if the patient has complied. So after the interview, the dental assistant corrects the errors that the patient made. Well, gee, I didn't get any exercise. And that happens. They won't do the exercise. And wait a minute, we know that exercise reduces depression. We know that it releases BDNF, brain-derived neurofactor, brain-derived and neurotropic factor. In other words, your brain grows from exercise. We know that. Look it up, kids. It's like exercise is critical to human existence. It's very important to health. And whatever it is that the patient did not do, the assistant sits with the patient and says, listen, it's so important. You probably have a calcium or magnesium deficiency, and we want to correct that so that you feel better, your muscles relax, right? We want you healthy. That's our goal. And I know that you've got a busy life, but we need to do something about making sure that you're healthy, because you're going to drive yourself into the ground if you don't take care of yourself. So that's the assistant does that with the hopes that you will correct any problems and facilitate the healing of this patient. Additionally, legally, it does help, because if they're not complying and later they completely yell at you and they say you're incompetent, I want all my money back, I can't believe that you're a dentist, I've seen some real nasty stuff. They've signed the consent form that they're going to comply. They know what the deal is with this program. Then they fail to comply and be a good partner. Now there's problems, and it's their fault, not yours. And it's really important to do that. As to whether you give them a refund or not, that's up to you. I prefer not to, because a refund often is an admission of guilt. It's like, I did something wrong. Here's your money back, right? And a lot of doctors don't think of that from a legal point of view. Again, the dentist does come in and performs a very brief TMD checkup, just like you do with the hygienist. You're doing a checkup for the cleaning, and determines if the patient should continue full-time wear and then or return again in 1 week for a second POSG1. So if they're doing really, really well, we say, well, okay, why don't you just go to nighttime wear? If they're not doing well, we might want the patient to come back a week again because they weren't complying, they didn't get better, whatever it might be. You want another follow-up appointment. And you say, listen, we love you. We're going to give you another free appointment just to check on you. But it is really important that you comply with the program. You do everything that's going to help you. You've got to wear this thing full time, or whatever it might be. I like for the assistants to be the heavy. In other words, give the negative criticism. You be the great, wonderful dentist. And we do that for legal purposes, not because we are ego. We want the patients to get mad at the assistant so they won't sue you. And you can then, if they're doing really well, you have them come back in 5 weeks, which will be the POSG, post-op soft guard, 6 weeks. And that's how long. It's a 6-week program. And if you look at the handout pamphlet that we give the patient, it's a 6-week program. They're paying for a 6-week program. I've had patients, I have one particular patient, literally a year and a half later said, oh, my TMD is back again, your soft guard didn't work. And this is like a year and a half later, and I was like, wait a minute, this is a 6-week program. It doesn't claim to cure anything. It manages the problems that you have. So again, this is 1 week. I typically make an hour. It could be a half hour. It's primarily with the assistant, not with the dentist. And the assistant needs to be a competent, loving, one-on-one individual who works with the patient and make sure that the patient is administering the program correctly. Wow, this is a busy slide, but just to clarify, we do a form, fill out a form, we do an assessment, series of questions to the patient at the end of 1 week. The soft guard is part of the tool. The soft guard is not the only tool, and you have to believe this too. But if you're a dentist, just like a carpenter, you're going to be thinking leveling and planing and nailing because that's all you think about. But if the person drinks too much coffee and can't sleep, oh my Lord, that's going to cause muscle problems. If the person is calcium deficient, it's going to cause cramping, premenstrual syndrome. It's going to cause all kind of other problems, muscle tenseness, just a lot of stuff. And these are very simple solutions that we provide to patients in addition to the soft guard. And they must do this stuff. If they don't do this stuff, you have less success. I want to be successful. Physicians know also patient compliance often sucks. Here they pay you big money, they want to get healed, but the very things that cause them to go sick prevent them from doing what you suggest to get them healthy. Then they turn around and blame you, and they know not what they do when they crucify you. So please, think of the best interest of the patients, understand they're human beings, and you want to get them on the right path. Also, if they fail to comply and later they try to sue you or negatively criticize you, you can clearly say, hey, you didn't do most of the stuff we asked you to do. So again, the evaluation, the 1 week TMD soft guard evaluation exam form is performed by the dental assistant. Preferably the same dental assistant that saw the patient the week earlier, who explained the 1 week, the 6-week program. And so we asked the patient, how you doing? Now, some of my front office staff are crazy and they'll give this form to the patient. No. This form is not given to the patient. This form is filled out by the attending senior TMD dental assistant. So how you doing, Mrs. Jones? And you circle better, same, worse, much worse. I always get involved if there's any kind of negative report. I want to know something bad's happening before it happens. And the next thing is, well, what did the patient say? Did they make any comments? And we always ask questions that we avoid. We don't want the patient to feel like we're after them, but in the same token, we want to see if they're doing everything that we recommended. And the first question is, hey, were you able to wear the soft guard very much? And that's like an open question. It's almost like it's okay if you didn't. But the answer is yes. We ask them to do 24/7. And if you open the door and they say, oh, yeah, I wore it as much as I could, but at work I took it out and sometimes I forgot it. Well, if they're not decompressing the joint, excuse me, how can it work? If you've got a broken leg and you take the cast on, you put the cast on, you take the cast off, put the cast on, you're going to get sick. You know, have your headaches decreased? Are you sleeping well? And these are things that I like to know about. Next thing is, I don't tell them anything. I ask them because they should know. Well, what vitamins are you taking? And if they can't tell you, they've probably not been taking them. Got it? Because they should know what they're taking. They went out and purchased the vitamins and they're taking them. So they should know what they are and what dose they are and when they take them. So what vitamins were you able to take? Almost like, were you able to do it or not able to do it? What's going on? And they should be taking at least 2,000 milligrams of ester C. They should be taking E, 800 to 1,000 IUs. Vitamin D is a universal deficiency. It seems like everybody's got it. And my physician gives, I'm not lying, 50,000 unit pills to patients. Crazy. And so they should know those. And if they're not doing it, and don't criticize them right then. Don't say, oh my God, you were supposed to wear this all the time. Why did you not wear it? You bad patient. No, 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 no. Do the assessment, then go back and sit with the patient, right? And maybe print out the 6-week program one more time, go over it, highlight the things that the patient wasn't doing. So what minerals were you able to take? And so we take cheap calcium, magnesium, and zinc. You can get them at Publix and just about anywhere, and it must be taken with food because guess what? We first started doing this, some of my patients would say they were pooping these pills out, meaning that calcium, particularly and magnesium, they need to be taken with food. That's how they're digested in nature. So, what minerals were you taking? And then sometimes they'll say, well, I have these 3 bottles. No, I want it to be 1 pill. Well, when did you take your vitamins and minerals? And they should say, at least with the minerals, 1 with every meal. Calcium, magnesium, zinc is absorbed poorly. So therefore, if they absorb like 25% with 1 pill, 25% in the second, 25 with the third, they're getting 75%. We're getting it into them. So it should be 1 with every meal. And they need a lot of water because muscle needs water to flush things out, keep hydrated 6 to 8 glasses a day. They must do some sort of exercise. Exercise is to decrease the depression. Exercise, we know, increases longevity. People heal better. There's less depression. Exercise is critical. And get this, exercise releases brain neurotropic hormone, BDNF. And it causes your brain to grow from exercise. Oh, Lord. So they're supposed to be doing at least 1 hour each day of walking, of light jogging, swimming, light running, bicycling, some sort of exercise. Well, were you able to stay off of coffee? You don't say, did you stop coffee? They'll get embarrassed. Okay. Well, what is it with coffee? Have you able to wean off of the coffee? Oh no, I'm still drinking the thick stuff 3 times a day, even late in the afternoon. Oh my God, don't say anything, just go down the assessment. So were you able to stop smoking? Smoking causes like 80% of periodontal patients smoke. Why don't periodontists have anti-smoking programs? Lord almighty. But anyhow, were you able to stop smoking? It's an addiction, kids, so it's hard. And that's one reason why we need to get them off of everything at once. When I first started this program in 88, 89, I was doing one thing at a time and they got bored. So I started getting them off of everything all at once. Cold turkey, it works better. And then did the patient comply with everything? Yes or no? And then what did they not comply with? Check off the things in the bottom. Now the assistant should very lovingly and caringly go over the program with the patient one more time if there are any deficiencies and things that were not done. This is critical. We want to correct the patient, but also we want to medically, legally protect our butts, right? We care about the patient, we want them to do everything to help themselves. So we're going to re-educate the patient. But if you don't care at all, you're never going to ask these questions, right? You don't care. You don't. And you're a freaking dentist, right? You're like, oh, well, I'm a carpenter. I put screws into wood and I put appliances in people's mouths. And as far as other things go, I don't believe in any of that. Excuse me? We are dental physicians. So this is the assessment. And again, it's available in the handbook, which is free. We also have a video course just on the 6-week program. You can go through that. Just learn that these things are essential. I wouldn't put it in here and spend this much time yelling if I didn't feel it was critical. I think, too, the approach to this is very important, that you're just asking questions, not reacting, not making comments until after the entire 1-week soft guard exam assessment is done. Then we go back. Because if the patient feels like you're going to yell at them, they're going to start clamping down on all the things they didn't do and not telling you the truth. Patient compliance is the #1 problem that most physicians have. It's recorded. We know this. And now we're getting into the realm of kind of medicine and medical management. And we're going to see things that we can't control. As a dentist, we do a preparation, put the crown on, cement it. We know the cement, we know the preparation, we know the materials. We put it in, we get a great result. We have control. But we don't have control of these patients when they leave the dental office. So what do we got to do? Educate, motivate, re-educate. So now we've arrived to 6 weeks, and it depends on what you're using the appliance for. At the Atlanta TMD Institute, we really don't have a 6-week soft guard appointment because we try to get the MORA, the Mandibular Orthopedic Repositioning Appliance, into the patient within 2 weeks. We put the soft guard in immediately as a emergency type thing and a backup. It's wonderful, works well on most patients. And then we don't do a 6-week soft guard. But many uses, if you look through our handbook, many uses of the soft guard are not for major TMD care. So you can use the soft guard for a treatment appliance for TMD for some patients. And in this particular case, we would have a impression appointment, a delivery appointment, DSG, deliver soft guard. Then we'd have a POSG1, post-op soft guard 1 week, and then a POSG6, which is the last appointment for a minor TMD patient, a person that's not having a lot of trouble. A lot of people in your dental practices. So have the patient fill out and sign a TMD patient self-evaluation form. After seeing the patient, the dental assistant takes range of motion measurements. After the interview, the dental assistant corrects the errors that the patient made, and the dentist performs a brief TMD checkup and determines if the patient needs additional TMD care. Do you need to escalate to a hard guard because they're not doing well, or are they doing well? I would say 50–60% of the patients we put the soft guard in and they do everything they're told to do, they do really well, and they don't need to progress on, nor do they want to, because it can be significantly more expensive, but better to go on to a hard appliance. But this would be a dismissal appointment in most cases. Again, refer back to the consent forms, really, really important, because the consent form defines what program you're using. So if you're just doing this for mild TMD management, you're done at 6 weeks. This is very important because the patient will call you up a year later and say, hey, what about my TMD work? And say, well, it's only we're supervising you for 6 weeks to see if you respond to this appliance. And if you didn't, we'd escalate, but you did. So, you can come in and take a look at you. But again, legally, the consent form protects you. It's a 6-week program. After that, you're done with the program. So the normal mandibular soft guard covers all the mandibular teeth, doesn't go on to the gum. But sometimes you have edentulous areas, like a completely posterior edentulous area in the right or the left, and you want to have contact to prevent overclosure. because when you overclose too much, it jams the joints into the ears, tears up the back of the, the joint. The retro means back, retro, discal tissue. And you can put one little piece of plastic and then do the suck down so that you have 2 sheets of plastic over the edentulous areas. And this is important, especially if the patient's symptomatic on the side that there's a missing tooth. You can convert it to a soft pivot splint, easy to do. All you do is go to that first molar and carve away all of the, and we don't normally do this, remember, but if we're converting it to a pivot splint, which is particularly good for recapturing discs, although this is not my recommended treatment, if you want to modify it, you can, use the horseshoe articulating paper, grind down, and then in front of the mesolingual cusp of the first molar, take some away of the soft material away, thermoplastic material away, so they're not touching any of that. So when they bite down, the first contact's the lingual cusp of the maxillary first molar, and there's nothing forwards. When they bite, it pivots. There's a lot of controversy about pivoting appliances, and we don't really want to get into it, but you can do this. You can remove the anterior facial and incisal thermoplastic material. All right, so cut that away from cuspid to cuspid, all that's cut away and smooth. And you can do just allow the front, it says a full anterior full arch deprogrammer. That usually I like deprogrammers on the maxillary, but you can do that and you just add a little bit of material. You cut out a little piece of thermoplastic material, you melt it with a torch, then you do a suck down. Now you're contacting the anterior only. And you can also do a maxillary suck down. For whatever reason, I don't like them, but you could do a maxillary soft guard. I prefer mandibular for various reasons. They speak better with it. I think the retention's better, and it doesn't interfere with swallowing. So I previously tried to get you involved in helping people because I get excited helping people. I really do. But in fact, money makes the world go round. And so now I previously appealed to your sense of helping others, which is very important. But also I'm going to make an appeal directly now to your pocketbook because I want you to think about running a program, soft guard program, and how it's going to help you stay alive and feed your staff and your family. In fact, brothers kill brothers to become king. And in the United States right now, things like our food pyramid are being run by agricultural companies, and sometimes not for the best interest of our population. Same thing with pharmaceuticals. People being given pharmaceuticals. We have more pharmaceuticals in the United States than any other country in the world. And we don't think about preventive ways because that doesn't make any money. Prevention doesn't make any money. But irregardless, let's look at a soft guard program in your office. And believe it or not, the hygienist is a key person. You'll be doing comprehensive exams on new patients, but the hygienist sees patients over and over and over again every 6 months, every 3 months, or 4 months. And there's no extra money to pay the hygienist because she's already doing or he's already doing the cleaning, bite wings, exam. The hygienist is sitting with the patient and there's no additional cost to you to have the hygienist screen patients. But once the hygienist determines that a person has a TMD problem, you verified it, then you turn it over to a dental assistant. And the dental assistant, if they're expanded duty, they're going to take the alginate impression, mandibular, pour that alginate up in diastone, trim that diastone model, do the vacuum forming of the soft guard, trim and finish the soft guard, and do the preliminary screening interview questions, and then take mandibular range of motions prior to the soft guard being inserted. Now, if you're paying the assistant $20 an hour, it really takes about an hour and a half time to do all those things related to getting the actual soft guard into the patient's mouth, right? And that comes out to be about a total of $30 additional for a soft guard, and that's minimal. In our office, we charge like $800, and insurance allows, I forget what the code number is, but insurance does allow between 50 and 80% many times for this appliance. But I'm treating the patient, not the insurance company. So you could, in fact, have your front office staff, what they call code specific, confirm the patient's insurance and try to get an idea of maximum payables so that you can offer the service, but it's a wonderful service and it is not that expensive. So it's $30 per patient coming from hygiene. So if you develop your hygiene program so that the hygienist knows to recognize signs and symptoms of TMD, i.e. very sensitive to teeth, limited ability to open the mouth that it opens but is very tired, trying to buff the teeth, doing a prophy paste thing and they hurt. These are things that we see, or unusual recession or periodontal disease that doesn't seem right. It just shouldn't be there, but it is. These very often have to do with TMD cases. But again, this is not an expensive pursuit, and you should be thinking about how this is going to increase your income also. So I'm tempting you from a money point of view to start getting interested. And this is how we'll look at it right now. So we're looking at yearly just soft guard TMD revenue, soft guard, right? If your dental hygienist screens and starts just one 6-week TMD program case per week for 50 weeks, then the total revenue for the year would be $42,500 if you're charging $850 per case for those 3 visits or so. In 10 years, the revenue amounts to $425,000 in soft guards. and get this, at the same time, you're helping patients, right? And most of them are going to be very appreciative, right? And if insurance covers it, all the better. Or if you get a company like Care Credit, which you'll give 10% to, so you'll give $85 for that $850 soft guard, right? So let's just say you're going to make $750 after the patient gets to pay over 12 months interest free, right? So they're paying like what, $75, something like that per month. Very little. But much more importantly, how many headaches are you preventing for your patients? My God, TMD patients suffer very often with headaches, hot and cold sensitivity to their teeth, bruxism, all other stuff. How much money are you saving your patients in medication? How many more good nights of sleep are you providing to your patients? Many of my patients come back and they just do extremely well. Everything's relaxed and nothing hurts, which allows them to get deeper sleep. And how many productive, pain-free days of work are you creating for your patients? It's a wonderful thing. This is like very little downside on doing soft guards for patients. Very little downside, almost always upside. So insurance does often or sometimes reimburse. So this is nice. I personally want to help people. I feel like getting involved with insurance companies is getting involved with the devil because they want to make profits, and I'm always going to have problems. It just always comes up. I don't want to get into all the issues, but they're just extensive related to insurance. I think I like talking about stories. Many years ago, a young woman, late 20s, I believe, 2 children, husband was a pilot and had very good insurance. He walked out on her, right? Not only did he walk out, he didn't provide any support for the house payments and the car payments. She just had a breakdown. And she went to her regular dentist who referred her to me. And she gets in the chair, she's broken down crying, and, I wanted to help her, but we don't take insurance in our office because of the problems related to it, the dangers related to it. But, she's crying. She was in a terrible situation. So we say, okay, here's what we'll do. We'll confirm your medical insurance with the airline carrier. And we were told 80% coverage medical. We were told that, and it was in writing. All right, so we say, all right, give us the 20%, which, whatever it might be. And we treated her successfully over the 6-month period. At the 6 months, we still had not got paid. Come about a year later, this is like 2 6-month periods, and we treat patients in 6 months. 2 6-month period, we get a check for about, 30% of the costs. So she paid 20, then there was 30, so it was 50%, and she owed 50%, right? Which was like $2,500. And when we called her to get payment, she went ape. Like, this patient went nuts on us, yelling, screaming. She lost it, completely lost it. And she drove over to her dentist's office and said, well, Dr. Podolsky promised to take the medical. I'm in terrible shape. It is rotten. He's unethical. And so the dentist calls me, and this is one of the few times in my life that I've been totally suppressed. He literally yells at me on the telephone for 10 minutes. I can't get a word in. So I finally say, oh my God, I'm just going to sit there and listen to him. And then, I explain, well, I'm very sorry, but he yelled at me. It was very degrading, very difficult. He was being the hero for that woman who lied. We never said that we were going to take only the insurance. And we put a lot of good time into her and got good results. But ultimately, I wrote off the balance, but you're not going to believe it. That dentist never sent another patient to me. She ruined my relationship. And as we said, patients can be crazy. I remember Dr. Stack had said that paid appliances work much better than unpaid appliances. And that's absolutely true. And people that are in active lawsuits never get better until the lawsuit's over. And we see that. But anyhow, some of the codes you can submit that relate to this in your regular dental office: panoramic radiograph, D0330, SoftGuard, D9940. TMD exam has a special code, D0150. And you can take diagnostic casts, which are D0470. So many dental insurance companies do cover the SoftGuard at 50 to 80%. Some dental insurance companies allow a new SoftGuard to be constructed every 3 years. You need to know this information, right? And be sure to add the above codes to your pre-visit dental insurance confirmation. So, and you could do what's called code-specific coverages, and call the insurance company and say, well, do you pay D9940, right? And they say, yeah, we do at 50%, or yeah, we do at 80%, or no, we don't. And then they don't often tell you the amounts, but you could get the patient to call, and very often they will tell the patient. They'll say, oh yeah, we cover SoftGuard at 80% with a maximum payable of $400. So you know what's going to be paid, and the patient will tell you what they told you, but they won't tell you, but they may tell the patient. But again, these are all technical issues, and honestly, I hate insurance. I really do. If you want to sit with me sometime and go over the things that I've seen and the problems that I've had, you're going to be amazed, just amazed. And we have a whole system of getting TMD paid for, which is extensive. And so we get the patients to submit immediately. They get refused 100% of the time, They say it's not medically necessary. Then we get a physician to write a letter of medical necessity. After they said it wasn't medically necessary, we resubmit. Most of the time they refuse again, and then we have to get Health and Human Services Director of the company involved. Just a bunch of stuff. It's extremely difficult and very frustrating. Recently, I've just saw that Georgia passed a law code that is going to assist us in getting these insurance companies to pay. But these are the codes that you need to know, and good luck with them. This is a new addition. Last year, or the year before, I think it was last year, the year before, Georgia passed a law, it's a mental health law, but they inserted in there, get this, look at the bottom, 332920, insurance coverage for treatment of temporomandibular joint dysfunction, of course it should be disorder, wait a minute, or surgery for deformities of the maxillary mandible. But it says that it does cover non-surgical treatment, and it's mandatory. We were all excited about this, and we sent out emails to all the people that didn't start over 2023, and it was a mess. The insurance companies don't want to do this. One insurance company sent us a list of questions about the patient with 23 questions. Is this person ever been suicidal? You know, crazy questions, and they're going to do everything they can not to pay. And it's just an evil type thing. It really is. You don't want to get me started at all. But dental, I try not to get involved much, although I'm finding that dental insurance is paying for soft cards, TMD soft cards, you know, pretty well, 50%, 80%, and I'm going to say maybe 2 out of 3 will pay. So regular dental coverage, you might be in good shape. But this is medical now, and the medical, when you do a full TMD case with a MORA, mandibular orthopedic repositioning appliance, hard positioning appliance, you do want medical coverage. We've got checks up to, I don't know, 3,800, 4,800, something like that. But I don't take it directly. But, you know, you want to help the patient whenever you can. But you have to remember, there's this company there that says, I want to keep my money. I don't want to give it to the patient. And then the patient's thinking, I have insurance. They're supposed to take care of me. And they put you in the middle. And it's not a good place to be. So I do not accept direct insurance. You may want to with regular dental patients, but this is something for you to think about, and you should come up with your own personal philosophy. So I think this is the Georgia law, and we'll go down to B, and it says no policy may be issued or issued for delivery in this state, which excludes medically necessary, get this, surgical but non-surgical treatment. This is your appliances for the correction of temporomandibular joint dysfunction by physicians or dentists professionally qualified by training or experience. So they cover surgery really well, and there are a lot of surgeons that do surgery, lots of it. I personally believe that once you've tore up a joint, it can't heal because you have to have all the healing components, particularly the periosteum, because that's where most of the growth occurs. That's a magical tissue. But again, if you look at item B1, that says it has to be covered. Whether they're going to pay or not, I don't know. Some of them will push it under the surgical deductible, which might be $5,000 or $10,000. But irregardless, it's a fight. And I hate this. I really do. And you're hearing me because I want to take care of my patients. But in the same token, I know that the devil comes in cloaks. I don't know what's going on, but they're going to fight me. You know, I had an accident in front of my office a year or two ago, and there was a major, you know, and she got the ticket. She hit me, and then she said there was no light there. There is a light there, and she argued it, and she got out of it in court, her ticket out of it in court, after lying a good bit, and then her insurance company said, we're not paying you for your deductible, even though she hit me and got the ticket. Eventually it worked out, and I did get that deductible paid by the other insurance company. But you have to understand, the insurance company doesn't want to pay, and why would you think that? And the patient, on the other hand, is thinking, I've got this insurance, that's why I have the insurance, that's why I pay. So we're getting into this, again, over and over. You hear me saying the same thing over, and you understand that I'm probably very upset about this, but this is what life is all about. So I want to take a moment just to think about defining what success is, and how this concept of success is very often disturbed from a dental perspective. But a student who receives a well done 80% grade, a B, that's a low B, but it's a B. It's an honors, right? In an activity in dental school, you got a B in your test, missed 20% of the questions presented. Think about that. 20% he didn't get right, or she didn't get right. That's a lot, right? That's 1/5 of the questions were wrong. But yet, this is a good student. And the thing that I'm trying to introduce now, you're saying, well, why are you talking about this? Is because in dentistry, we do some amazing stuff. We got great materials. We're trained well. It's just, everything is really nice. We put a crown in. I have crowns that I put in 1981, and they're still walking around, or they're buried, and they're still there, same ones. The technology that we have is phenomenal. And restorations are done well. Everything we do is very mechanically well done. And we have this concept, Lord Almighty, if this crown fractures were a bad dentist, we did it incorrectly, the preparation wasn't done right, whatever it might be. But you need to start looking, I'm introducing you to the concept that physicians don't think like us. Pain, the area of pain is not the same as dentistry, and that you need to evaluate whether you've done a good job or bad job based upon how professionals in pain evaluate themselves, not dental requirements, because dentistry is phenomenal. We have an incredibly good success rate. So one of the things I'm going to try to do is to get you to start thinking more like a physician, a neurologist, psychiatrist, because they think differently, because they deal with pain patients, and particularly neurologists. And what is success? Got it? What is success? And I took a grueling course. It took like 9 months with Rutgers in orofacial pain. And man, this is one of the things that I learned that I thought was amazing, right? Even though I suffered through the course. It's treatment success in medicine. How does a neurologist evaluate his treatment success? So the first concept is number needed to treat, NNT. That's an actual statistical number associated with medications. It's the number of patients that need to be treated for one of them to benefit, compared with the control in the clinical trial. So when physicians use meds, they know the number needed to treat might be 1 out of 5. So they only have a 20% chance of being successful, right, when they start out. And they know that. Got it? And so dentists don't think like that at all. It's like, no, you put this denture in, it's supposed to be very good, or you put a crown and it's going to last forever, right? I mean, I have gold crowns that actually porcelain to fuse to metal crowns that have been in there since 81. And we have to start thinking differently. The second thing is number needed to harm. So physicians will give medicines to people, that they know maybe 1 out of 3 patients will be responding, 1 out of 5, but some of the meds they give will possibly harm the patient, and they know that when they walk into the treatment. So number needed to harm, NNH, indicates how many persons on average need to be exposed to a risk factor like a med over a specific period to cause harm, an average of 1 person who would not otherwise be harmed. So they know when they enter in that they're going to be modifying, changing, messing with their treatment in order to fine tune it to get it as best they can. They know that when they enter into it. With dentistry, it's more like, oh, this soft guard didn't work, I must be an idiot, right? Or there are lots of reasons for soft guards not to work. They do work, and probably half of people really, really well. Number needed to treat, 1 out of 2, right? And we accept that, right? And it's okay. So if a person comes back and they're not fully healed, doesn't mean you're an idiot. It means that that's what that treatment process results in. Got it? If the treatment you provided was not fully successful, you must reevaluate the initial working diagnosis and previously applied treatment strategy. This is the problem. People will put a stabilization appliance and the patient will get sick and they'll say, get out of my office. This is a wonderful appliance. You're crazy. You must be nuts. Or, I didn't do anything wrong. I was taught this by my mentor and this is what I'm supposed to do in every single case. And you start getting mad at the patient instead of saying, okay, what caused this not to work, right? And what are my other strategies? What are my other things I've got to do, right? And that's important in TMD, right? You need to know what you're doing and to evaluate your own performance and yourself. Take a good look at you, take a good look at your appliances, and take a good look at the patients and change things until you get better results, right? I was taught this, right? This is the scientific method, and we should be applying it in our treatment of TMD patients. So you must reevaluate the initial working diagnosis and the previously applied treatment strategy. Failure of initial care does not mean that you're incompetent. It simply means that the problem is more complex than you initially thought. So now you need to throw yourself into that and find out what's going on. And this is part of the learning process. You learn from treating patients. It's very important. You're not indestructible. You're not perfect, and we don't expect you to be perfect. Here's a picture of Babe Ruth, the Babe. I mean, he is a legend, and everyone knows about Babe Ruth, not just the candy bar, but Babe himself. He was just incredible. He was considered the #1 home run hitter in history, supposedly. Notice that the Babe has a Red Sox uniform on. I come from Boston, and he was originally a Boston Red Sox player, and the Yankees stole him. And to this day, well, up until the curse of the Babe, where we couldn't win the the World Series, we always blamed it on this. But the Babe, arguably the most famous baseball player in history of the sport of baseball, was also known as the king of strikeouts. He led the American League #1 in strikeouts in 5 years, and accumulated 1,330 of them in his career. But we think of the Babe as a home run hitter. We don't think about his problems and his strikeouts. And again, I'm trying to get you to the idea that it's okay to fail. And that's why this appliance is okay. Because a lot of people are going to say, well, oh, wait a minute, it's only 50% success rate, absolute success rate with TMD care. But it's a learning process. It's a tool, and you're going to use that tool, and you should not be embarrassed when the tool doesn't work because you used it as best you possibly could. Got it? There we go. So now that you've learned a little about soft guard therapy, I'm just going to review, the Atlanta TMD Institute's future and what we hope you'll be part of, and some of the plans that we have. So we will be presenting intermediate concepts, which is a course. This is part of your basic concepts. And it will involve head neck anatomy review, reading panoramic radiographs of the signs and symptoms of TMD. I have a book that I published that, again, the book's free in PDF, TMJ MRIs and CAT scans, ear, nose, and throat relationships, review of comorbid conditions and concepts, comprehensive TMD exam and documentation, the modified FARA night appliance, its theory and the concepts of bruxism and sleep disturbances, daytime repositioning appliance, the MORA, theory, adjustments. I'm spending a lot of time. I'm trying to get you something to do. Dentists want things to do and to make some money, right? So I've had the concept, well, maybe I shouldn't present something to you until you know what you're doing. And unfortunately, that's not how people normally learn. So the MORA course, I'm working on that concurrently, even though you don't get all the theory, and I want you to get the theory. Jumping into the MORA is what I initially did in 1982. And I learned the hard way throughout 10, 20 years, the problems associated with that. And I'm trying to avoid it for you. And I've done a lot of writing. But the problem with writing is people don't like to read. However, as you start treating patients, you're going to start, I hope and pray, asking, well, why did this fail? What could I have done different? And how could I have been better at what I do? And then changing, retreating the patient successfully and learning. This is part of this whole thing. We also, on the MORA, we go theory and adjustments, and then physical therapy for TMD. This is extremely important, particularly with cervical issues, because absolutely cervical issues are one-to-one with TMD. We can go over this. We see it all the time. I've been doing this for so many years. We have all these contrary papers and pro papers, but listen, you'll see as you treat patients, regardless of what papers say, because papers can say one thing or the other, that these cervical issues are really important. And how to write physical therapy prescriptions and how to monitor the physical therapy. But these are other things that we plan on presenting. This was part of a course, but I think ultimately we need to break this out into separate courses, and that will be coming. And again, I'm hoping that it will be free and we'll be able to do it through internet so that you'll be able to learn well. My encouragement also, please get copies of the PDF books. Please take some time, an hour or two a week, to sit and read these things and think about them, and especially if you're using an appliance. So if you're going to do a soft guard, come back and review this course and read the soft guard handbook and read it and look at the complaints and look at the various things that you can do so that you'll become better and better and better. This is a process. The problem is people just don't understand. You know, I had a well-known cosmetic dentist who was involved with an organization here in Georgia, and he wanted me to speak in the morning at a UGA football game, you know, for the organization. And he said to me, I want you in like 2-3 hours to give me everything about TMD and don't hold anything back. I found that incredibly insulting. And unfortunately, I responded incorrectly. But irregardless, his thought process is, this is easy. You know, it should be really, it isn't easy. There's a lot of stuff you need to learn, but it's extremely fulfilling when you do this work. So I created the Atlanta TMD Institute to help patients and help dentists and help physicians and physical therapists. And I'm wanting very much to help people. It is true. And I've got everything there for you to learn. And if you need direct encouragement, I can get involved with helping you treat cases. I prefer that you learn and read because case reviews, I'm going to have to charge for that. But I want you to get involved, jump in. But we do have a case review service. So but get this, you're going to have to do all the documents and get everything written up and case histories and exams and radiographs and other stuff so that we can help you properly manage a case. Two, the courses, we want to present more and more courses with more advanced techniques. And the three, the Atlanta TMD Institute Study Group or Club, it hasn't happened yet. Probably going to be online. And you are looking at this. If you're interested in it, you need to let me know because I need to know if there is an interest and a way to put the time into it. Got it? Next thing is the Atlanta TMD Institute accepts most TMD treatment failures. So believe it or not, the money right now to do all these things that we're doing with research and writing comes directly from the income related to patients that we treat. It does. We don't have a foundation where dentists, maybe we will, where dentists donate money. And so at this point, if you are having a problem with a case and you want to tackle it, you can do a case review. If you get into trouble, that's what we're here for. Send the patient to the institute, we'll correct it. And that's another way of learning too, because you'll see how when we treat the case, what we're doing, and you'll learn. This is very important. So I have all these dreams for the Atlanta TMD Institute. I really do. I'm old, and honestly, I've made my money. I've been blessed by dentistry and blessed by life. Everything I've done, God's blessed me, and He has, or she. And so we plan on increasing the activity and courses. I love courses. I like giving them. I like answering questions. So TMD intermediate care would be with the two appliances, the MORA and the modified FARA. TMD advanced care with comorbid conditions review. Well, advanced care means troublesome patients with difficulties and other underlying other medical problems and comorbid conditions. It's just I wrote a whole book on the etiology of TMD. Please read it, and that will prepare you for this course. Or you don't have to take the course. Just read it. I've got everything there for you, right? Cadaver dissection for TMD. That's kind of important because you need to look at patients with a 3D radiograph in your mind and put things together so you can visualize stuff, right? And then TMD intensive etiology review. That is my book, which does relate to comorbid conditions, but a heavy-duty etiology background. We have a book on comorbid conditions. We have a book on etiology also, two separate books. The etiology book is detailed, 200 pages right now in 2023. Comorbid, we're starting. It's another book I'm working on. And these books take, on the Lord, 5 to 10 years to write. Brendan Stack, who is very well known, wanted to edit my etiology book when we discussed it. I never finished it in time and get it to him in time. But that's just, I was stupid, right? But this is the way it works, how my mind works. The study group, Atlanta TMD Institute, TMD study group with treatment support, 10 cases. This is something that I'm thinking about doing. I don't want to charge, but if I'm putting a lot of time into specific cases, I have to. So I don't know, we'll look at some options to assist you in your pursuit. There will be a TMD mini residencies where you come for a week, let's say, or 3 to 4 days, work with me directly with TMD, or we may have courses that specifically do mini residencies, except that I'm going to have courses all over the place, reading all over the place, things that are there for you to get involved in. And I prefer that you do the reading first. I've poured over these issues, dissected everything out, written things beautifully for you to have it there for you. And then if you read everything before you come to a mini course or mini residency, you're going to get a lot out of it. It's just going to blow you out. I remember, I started an MBA course at Georgia State a number of years ago, and I really had time. I think, particularly the marketing course, I did all the required reading before the lectures, which is something I couldn't do in undergraduate biochemistry. And man, when I went to those lectures, I just absorbed things like a sponge, and and then I would ask questions, and I think there were 180 people, and I had the #1 grade when we did our finals, and that's because I approached it differently, and I want you to approach this differently also. Got it? And then always, the Institute needs people to help it grow, and I will have a 1-year paid TMD residency, and it will be at the Atlanta TMD Institute facility, and working directly with patients and directly healing people. There you go. But thank you for listening to me during this, thinking, understanding what we have in store, thinking about things. I'm very appreciative that you spent the time. And now I'm just going to give a few closing remarks. I just love Teddy Roosevelt. I really do. He was a sick kid, worked, his father encouraged him to strengthen himself, and all throughout his life, Teddy Roosevelt worked hard to accomplish good things. He really did. And part of his life was tragic, and because his wife and mother died on the same day, and just lots of stuff. But he's one of my heroes, along with Winston Churchill. I look at them almost as the same type of people. But Teddy Roosevelt made a statement which I thought was really strong, and I've used it in my life, and I hope you'll use it in your treatment of TMD. Got it? So it is not the critic who counts, not the man who points out how the strong man stumbles, or where the doer of deeds could have done them better. This is a critic, right? He's talking about the person who's going in there and doing things. The credit belongs to the man who is actually in the arena, whose face is marred by dust and sweat and blood, who strives valiantly, who errs, who comes short again and again, because there is no effort without error and shortcoming, but who does actually strive to do those deeds, who knows great enthusiasms and great devotions to TMD, who spends himself in a worthy cause, who, at the best, knows in the end the triumph of high achievement, and who, at the worst, if he fails, at least fails with daring greatly, so that his place shall never be with those cold and timid souls who neither know victory nor defeat. So let's get in the arena. Let's start treating patients. Be valiant and know that you're going to err. That's part of the learning process. You're going to get bloodied up, and it's just going to happen. And so go forth with the knowledge you can. Be prepared. Prepare as best you can for the war. Like a warrior. I think of myself, unfortunately, like that. You need to learn as much as you possibly can and prepare yourself for all situations. So once you get into the arena, you're properly ready for the fight. And that's true. We can use that analogy with TMD. And so please spend your time. I'm encouraging you especially to read my books, because I've poured over those books so hard, and they really light the light for you. And again, get in there, start treating patients. You're going to make mistakes. We expect that. Life is very interesting. It really is. A number of years ago, I found out that I had Irish blood in me, particularly from Southern Ireland, possibly Viking. It's just so interesting. How it got there is a big question, and we don't want to get into too much discussion about that, but it is there. I'm a quarter Irish. I'm a quarter Belarusian, my grandpa. I'm a half Austrian from my mother's side. And so there you go. But the Irish in me is very special. It really is. And I just love being Irish. Isn't that crazy? So here is a saying that, a poem, I guess, that I felt was extremely important, and that it grabs me. And so I'm parting with you on this course with this wish for you. May the road rise to meet you. May the wind always be at your back so you'll sail where you have to go. May the sun shine warm upon your face. The rains fall soft upon your fields. And until we meet again, my friend, may God hold you in the palm of his hand.